Papati ma'am to help us in conducting and supporting CME program. And I would also like to thank Professor Padma madam for coordinating us in the CME and helping us to conduct the program. Now I would like to call upon our respected Dean, Dr. E. Terani Rajan, MD, DCH. Sir has sent his audio message towards the successful inauguration of the CME. We would like to play his audio message for the further process of the CME program. Thank you, sir. Next, I would like to invite our respected, eminent, and beloved director, Dr. S. Elirarasi Madam, to deliver a few words regarding the CME program. Kindly take over.
Good morning, one and all of you. I take this wonderful opportunity to welcome all of you for this CME to commemorate the World Down Syndrome Day and congratulate the Department of Pathology for organizing this. Unfortunately, it has to be a virtual CME because of this corona pandemic. First, I thank obviously our DME and Dean and HL for giving us a wonderful cytogenetic lab so that we can focus on the genetical anomalies and also spread knowledge about the diagnosis and treatment of these syndromes. I thank Dean sir for his message and starting the program. I also thank all the assistants of pathology who are, and welcome all the audience who have come in Zoom in all or directly in this platform and who are going to have a feast for a day full where they are going to see a virtual tour of cytogenetics, learn about the leukemias, though it is actually a disease, Down syndrome day. The department head, Dr. Papati Madam, is converted into a genetic and a rare disease symposium. So all of you will get to hear a lot of knowledge. You learn a lot of things on this today. I wish this program all the best, and I think we will start the program without any other delay. Thank you. Thank you, one and all.
Thank you, madam. Now, I take the pride to introduce our professor and HOD, Dr. S. Papati Madam, who has been the person in establishing the molecular lab at ICH Egmore. Madam has been conducting various training programs on thalassemia, and she has been an expert committee member in thalassemia screening programs. And she has presented various papers and posters and has done many publications in index journals. She has also been an editorial member of e-journal of Dr. MGR Medical University. So I welcome Madam to, and I welcome her to take us on a virtual tour on cytogenetics at ICH and the achievements and statistics at ICH. Kindly take over, Madam.
Good morning, one and all. Thank you so much for your kind introduction. And at this outset, I should thank our government of Tamil Nadu and our health secretary sir, DME sir, Dean sir, and our director madam. And now I'll take you on virtual tour on cytogenetics at ICH and few words about our achievements and statistics. So, what is cytogenetics? The study of structure, function, and properties of chromosomes, chromosomal behavior during mitosis and meiosis, chromosomal organization and expression, and its influence on the phenotype, the factors that cause chromosomal changes. What is chromosome? Chromo means colored in response to dye. Some means body. So human, they contains 23 pairs of chromosomes. 22 pairs are autosomes. 1 to 22 are autosomes, and one pair of sex chromosome. Either double X is a female, XY are male, as we know. So what is karyotyping? A display or photomicrograph of an individual's somatic cell metaphase chromosome that are photographed during cell division and arranged in a standard sequence. Usually it's based on number, size, and type. And what are the information we are going to obtain from karyogram? So number of chromosomes, sex chromosome content, presence or absence of individual chromosomes, nature and extent of large structural abnormalities. So conditions where the analysis is recommended. So early growth and developmental disorders, ambiguous genitalia, amenorrhea, fertility problems, neoplasia, pregnancy in older women, if there is any history of spontaneous abortion and history of hereditary disorders or consanguineous marriage. So cytogenetic is either it is a cancer cytogenetics or your conventional cytogenetics. Both need the molecular cytogenetics that include FISH and microarray. So this is our workflow. When the patient come to our department, we do the basic chromosomal analysis, then molecular cytogenetic analysis, then molecular analysis, and we will do the these tests for the family of the patient also. So this is our departmental cytogenetics workflow. The first, initially, we should collect the blood in a heparinized tube. This is our lab. We are doing the culture, then harvesting, slide preparation, staining, then report and analysis with the microscope, spectral microscope with the software analysis. So a few words about our department. In 1968, our Department of Pathology started functioning at ICH with a clinical pathology lab. In 1987, our department expanded with the histopathology and cytopathology lab, and later upgraded with hematopathology, frozen section, and fetal medicine. In 2018, the inauguration of our molecular pathology lab with conventional karyotyping, FISH, spectral karyotyping, conventional PCR, RT-PCR, and flow cytometry. So conventional karyotyping was started in November 2018. Our first case is reported in the month of December 2008. So far, we have completed 323 cases that includes Down syndrome, facial dysmorphism, global developmental delay, DST, ambiguous genitalia, CAH, Turner syndrome, leukemia, Edwards syndrome, Jacob syndrome, and BAM, Hippolydoid syndrome. And parents and siblings of the index cases also, we are doing the test. So this is our Department of Pathology, Molecular Pathology Lab. It's our lab with the latest equipments, RT-PCR and flow cytometry, and here's our spectral karyotyping. So coming to our, so far we have reported 323 cases, in which actually we have reported so far 1 or 2 cases of Down syndrome and 9 cases of Turner syndrome. And so many rare cases, 1 Klinefelter syndrome and 2 Jacob syndrome. So this is our karyogram for normal 46XX and 46XY. And some interesting cases they have observed: Down syndrome with Robertsonian translocation, and Klinefelter syndrome, Jacob syndrome, and Turner syndrome, short stature with the Turner syndrome with the mosaics. So it's the trisomy 21, Turner syndrome, only one X chromosome. So XXY Klinefelter syndrome. So the translocation and deletions, duplication, Robertsonian translocation, and the Turner's mosaic karyotyping in a patient with a short stature. These patients, they won't have the normal clinical features of Turner syndrome. So with the karyotyping pattern, karyogram, we are given the diagnosis of mosaic karyotyping. And this case is published in the indexed Journal of Clinical and Diagnostic Research. And our acknowledgement. So I would like to thank Almighty Force for providing the opportunity to work in this department. And I express my special appreciation and heartfelt thanks to our Honorable Chief Minister for inaugurating the Molecular Pathology Lab in 2018. And my earnest thanks to our Honorable Health Minister, and heartfelt immense thanks to our Health Secretary, sir, for their support and constant encouragement in upgradation of our Pediatric Pathology Laboratory and establishing the Molecular Pathology Lab in ICH. And I would like to thank our Dean, sir, for extending his support. And my thanks are due to our Madam Elarsi ma'am for her unconditional support. And I greatly appreciate and acknowledge the support I received from this institution. I'm extremely thankful our previous director, sir, Dr. R.S. Siralar, sir, former director and superintendent, who was the backbone in the setting of this department. And thankful, I'm extremely thankful again to Dr. Chandra, madam, retired associate professor from IBMS, for valuable guidance and timely suggestion and support in Cyto-Dentist reporting. And my sincere thanks to my colleagues, juniors, assistants, and PGs, lab technicians, Cyto-Dentists, and other members of this institute. And my humble thanks to Libera Foundation and Lions Club for Chennai for their support to the Cyto-Dentist. And thank our Tamil Nadu and Pondicherry IAPM chapter and its, our pediatric city pair, city Chennai branch. This is March 21st World Down Syndrome Day, so our favorite logo. This is some happy moments. Our first karyotyping report released by the director ICH. So these are pictures from a CME conducted by our department in World Down Syndrome Day 21st, 2019. That time we honored some of our Down syndrome babies, and because of this Corona pandemic, we are not able to do this. So next year, probably by Almighty's wish, we'll do that. So this is our Department of Pathology. Thank you, one and all, for giving this opportunity. Thank you so much.
Delighted to introduce our energetic and enthusiastic professor and HOD, Dr. C. Ravichandran, sir. Sir has been a health specialist of UNICEF office, and also he has presided as a state training coordinator. He is a member of expert committee for pediatric and hematologic oncology guidance for pediatric COVID disorders. And he has involved in various research activities and conducted many training programs for health workers and medical officers. Now, I call upon Sir to deliver his talk on hematological disorders in Down syndrome. Kindly take over, sir. Sir, you can start sharing your PPT, sir.
Sir, please unmute your screen, sir.
Yeah, thank you for giving me an opportunity to meet this august audience. I'll just try to share my screen. Can you please tell me whether it is visible? Is it visible, ma'am?
So visible, sir. Make it as a full screen, sir. Yes, sir. Yes, sir.
Yes,
Fine,
sir.
sir. Fine, sir. You can proceed, sir.
This is not a full screen?
Now we have got the.
Yeah, okay. Yeah. So I know I'm addressing a huge audience of learned people. So what little experience we have, we would be sharing with you. So I think Anu has already made my job that much easier by talking about the Downs and the genetic manifestations and all that. So I would concentrate only on the hematological manifestations of Downs and its import for the management of cases when they present to us with the blood diseases as such. So is it important that we should look for blood diseases and malignant conditions and congenital disorder like Down syndrome? Yes, it is very important for the simple reason that Down syndrome people are prone for benign and malignant blood diseases as such. So just like they are very commonly affected with hypothyroidism or with the what we famously call the atlanto-occipital dislocation, the population-based and cancer-based registries and clinical trials suggest that if a child has a Down syndrome, then it has 12-fold increased risk of ALL, that is acute lymphatic leukemia, between the period of 5 to 30 years of life. Now, if the age is less than 5 years, they have a 40-fold increased risk of ALL, acute lymphatic leukemia, and if the age is definitely below 5 years, there is a 150-fold increased risk of AML. So having talked about the malignant blood disease, the benign disease also brings with it its own confusion to us. The predominant manifestation of a Down syndrome in the neonatal period is the transient neonatal leukemia or the congenital, so-called the congenital leukemia. And this is otherwise a transient abnormal myelopoiesis as such. So I have divided it into roughly two groups. The one is the neonatal Downs and the other one is the infancy and children as such. So hematological abnormalities in Down syndrome in the newborn period is well remembered by the mimic hands. Hematological abnormalities in neonatal Down syndrome. So if you remember your hand, you know that there are hematological abnormalities. So these are usually the commonest ones are transient abnormal myelopoiesis, which we will be talking about. And then you have non-specific changes which are associated with the train growth restriction, the IUGR and the trisomies. So this is not only confined to the Down syndrome, but generally as such. So because I am highlighting it here because in Down syndrome, there are certain variations as such. So you will find that most of these IUGR babies and trisomies have neutropenia, thrombocytopenia, erythroblastosis, and polycythemia. They also have subtle myelodysplastic features like abnormal myeloid cell granulation and giant platelets as such. So these are the common abnormalities that we see with Down syndrome in the newborn period. So polycythemia, macrocytosis, thrombocytopenia, thrombocytosis, and leukopenia, which are less common. Leukemioid reactions and neutrophilia are more common. And as we know in our country, iron deficiency anemia. Only thing is there are certain subtle manifestation changes which we have to keep in mind when we actually investigate a child with Downs for iron deficiency. I'll be coming to it a bit later. So in terms of percentages, if we have to look at what are the benign abnormalities, you will find that 80% of the Down syndrome have neutrophilia. Does it have a clinical significance? Yes. In our setting, where we tend to make a diagnosis of sepsis on and off based on subtle signs. So if a child has a neutrophilia, then it is always taken as an infection. And then antibiotics are instituted because the results are going to take some time to come. There is a newborn septic scoring which they would do. And in the newborn septic scoring, you will have band cells, the immature to mature neutrophils and neutrophilia, all of them coming together in it. mind you, this is a benign blood disorder without any infection. These Down syndrome tend to have 80% neutrophilia. Along with the neutrophilia goes the thrombocytopenia. We always call that thrombocytopenia is the commonest and earliest manifestation of a sepsis. But these children, 66% of them do have thrombocytopenia as a abnormality inherent due to Down syndrome. So whenever we have a case of Down syndrome, we need to keep these two in mind and not rush into a diagnosis of sepsis. So 80% neutrophilia, 66% thrombocytopenia, and 34% of them do have polycythemia. So we need to identify sepsis by some other mechanism than this. But if a child presents with neutropenia, then it is definitely not due to Downs. You will have to investigate for something else. So what happens to all these conditions? They are very self-limiting, tending to disappear by 3 weeks of age. The polycythemia, about which I have not yet commented, 34%, is irrespective of whether the child has got a congenital cyanotic heart disease or not. So if they have congenital cyanotic heart disease, they do have a polycythemia. We are not talking about that polycythemia in a Down syndrome. So they may not have any polycythemia because of cyanotic heart disease, but per se, because being a Down, they have a 34% chances of a polycythemia occurring. The reason is that it is supposed to be secondary to increased fetal erythropoietin levels. And this polycythemia usually takes about 2 to 3 months of life to disappear, provided they do not have a associated cyanotic congenital heart disease. Macrocytosis. So why is it important? Because whenever we do a CBC, we always look at the MCV. MCV is the most important parameter in the entire CBC as far as the hematologist is concerned. It gives a clue to the diagnosis. So a macrocytic anemia is, we all know, a feature where there is the cell is huge. There could be a maturational arrest, and invariably the ones with the bone marrow failure syndromes tend to have macrocytic anemias. So here in children with Down syndrome, 2/3 of them continue to have macrocytosis throughout their life. So what is the importance of this finding? So whenever we look at iron deficiency anemia, we look for microcytic hypochromic anemia. And in this condition, in the Down syndrome, they will present with macrocytosis. So a clue to iron deficiency anemia does not come from MCV in Down syndrome. So we may have to do not only ferritin, but along with that CRP, because they are also prone for infections very often. So 2 parameters are required along with in the presence of a macrocytosis to diagnose iron deficiency anemia in a child with Down syndrome. And these children should be closely monitored for myelodysplastic syndrome and acute leukemia or TAM as they grow up. So now we are talking about the newborn period as such. Let us look at the infants and children. If you look at the infants and children, the myeloid leukemia is the commonest. We saw that less than 5 years, they have 150 times the risk of developing myeloid leukemia. But what is also known is that these children usually tend to have a myelodysplasia. They also are equally prone for acute lymphatic leukemia. Above 5 years, paradoxically, it is ALL which is much more common. Deals with the general trend that if you look at leukemias, 85% of them are ALL and 15% of them are myeloid. So it goes with that. So as I had already told you, polycythemia persists in the infants and children, and the other 2 conditions which also persist in children and infants is reduced number of B lymphocytes and thrombocytopenia. So what can all this be attributed? So I did refer a lot of books to find out why these people should have all this. And so I found that the extra genetic material in chromosome 21 actually confers a proliferative advantage to the hematopoietic cells. And this is what makes them prone to further karyotypic insults. So we will be coming back to it again later. So probably this explains that if ever there is an extra chromosome in 21, there is a proliferative advantage to the hematopoietic stem cells, and the spectrum of myeloproliferative disorders which occur will consist of myelofibrosis, myeloid dysplasia, and megakaryocytic leukemia, which we see. The further molecular genetic studies have actually demonstrated that the chromosome 21 has loci for enzymes involved in purine biosynthesis. Maybe correlates with the proliferative changes which occur following the conferring of an extra genetic material on chromosome 21. So let me now go with the case that we saw. This had happened about 3-4 months back when we had a call from the newborn ward, a 3-day-old baby with Downs. So they referred to us saying that this child had very high counts, a count of about 2.5 lakhs microliter per microliter. Hemoglobin was 14 grams, the platelet was 1.2 lakhs, and MCV was 110. The clinically, when we went and examined the child was on nasal prongs, had a massive hepatomegaly with ascites. The liver function tests, the renal function tests, and the uric acid were normal. The peripheral smear revealed 40% blasts, predominantly of the myelo group as such. So the diagnosis is staring. So we sent the child's blood for flow cytometry. The flow cytometry came as transient acute myeloproliferative syndrome or AML-M7. So for this child, we started with the low dose cytarabine at 20 milligram per meter squared per day, and keeping the daily counts and monitoring the daily counts. We gave it for a period of 7 days along with the allopurinol and to prevent the tumor lysis syndrome. And on the 8th day, the WBC counts were to about 14,000. There was a significant reduction in the hepatomegaly. The ascites disappeared. The child was sent. So we also reviewed our cases which we had seen. So we found a similar child which was diagnosed about 2.5 years back, and very similar findings. Maybe the counts were slightly on the lower side, somewhere around 1.8 lakh. The dose of cytarabine was also the same, and this child was followed up, and at 2 years of age, this child is still on follow-up, and we don't have any evidence of AML developing this child currently. So now we have 2-3 children who are presented with TAM to us, survived and are on follow-up. So what is this transient abnormal myelopoiesis or transient myeloproliferative disorder as such? This is a hematological disorder which is almost 99% confined to Down syndrome. Can present during the fetal period or in the neonatal period, or maybe in the immediate post-neonatal period. All children with TAM need to be followed up because they have a tendency to transform into acute leukemia, which is called as the myeloid leukemia of Down syndrome, MLDS. This transformation is supposed to occur in 20 to 30% of the cases with the TAM. If you look at the general trend as such, you will find that Down syndrome, in Down syndrome, 10% of all the newborns where a diagnosis of Down syndrome have been made, they tend to have TAM as such. So in both TAM and the myeloid leukemia, the common factor is that GATA1 mutation is there. So we try to look at the literature again to find out what is the link between the TAM and MLDS. So TAM is now considered as a pre-leukemic phase of MLDS. They have near identical morphology, immunophenotype and ultrastructure of blast cells. GATA1 mutation is found in both TAM and MLDS, indicating that they come from a common cell origin. Why should we be interested or should be excited about TAM and MLDS is TAM and MLDS are a classical model of pre-leukemia going into leukemia, and in case we can actually break into this code, maybe we will know how leukemias evolve and targeted therapies can be seen in future. So the fetal hematopoietic cell has to be trisomic for chromosome 21. It doesn't occur in any other condition. And acquisition of a GATA1 mutation results in the production of N-terminal truncated GATA1 protein. It's a weak oncogene which fails to control the excessive myeloproliferation as such, specifically the megakaryocytes. So if we look at the model as such in the next slide, we will find that not all TAM progresses to DS, MLDS. So in the fetus, we know that fetus with trisomy 1 is roughly about 1 in 700. So the somatic GATA mutation occurs in less than 30%. So between them, you have large clones, that is more than 10% blast, and then you have a small clone where there is no increase in the blast cells. So if you look at the large clone in the neonatal period, they 4 to 10% of these tend to present with clinical TAM as such. And within that, by about 6 months, with 20%, they have less than 20% mortality rate and survive. The clinical TAM, 4 to 10% of them, a majority of them actually go into clonal extinction, and beyond 6 months of age, they do not progress on to MLDS as such. But of the clinical TAM, about roughly 30%, and of the silent TAM, a little bit, which is a small clone, which does not manifest, they undergo an additional genetic mutation. Remember that according to the previous slides also, we saw that they have a tendency for further genetic mutation. So whenever they have an additional genetic mutation, then they tend to develop myeloid leukemia, MLDS. But the important thing is that they have 80% survival rate. 20% of them die, and we will look at the reasons as to why they die. So the silent TAM, majority of it undergoes clonal extinction again, and there is no MLDS. If there is no somatic GATA1 mutation, they don't have TAM, they don't have MLDS. So this actually captures the the relationship between the transient abnormal myelopoiesis of the newborn with the MLDS as such. So there are another 1 or 2 hypotheses which I would like to just elaborate. One of the hypotheses elaborated is that there is an increased sensitivity of Down syndrome cells to interferon, and this causes aberrant antigen expression leading to autoimmune disease. This autoimmune disease in the bone marrow manifests itself as premature egress of the blast cells, inflammation and imperfect repair leading to myelofibrosis, and the binding of the autoantibodies to cell nuclei results in malignant transformation leading to leukemia. So in this hypothesis, if what is said is true and evidence in future happens to prove this, then the important thing is that if you can identify a therapy which will block the effects of gamma interferon, then this might be a useful step in the management of the leukemia, and the same hypothesis may be extended to viral infections also. Very interesting, very exciting. Maybe research for future. So how do TAM present? They present usually with hydrops fetalis and anemia in the gestation period. You will also see that they also have at birth hepatosplenomegaly, and because of myocardial infiltration, you will find that they have poor contractile function as such. So the different combinations which are possible, not that all of them should be present, the different combinations possible are hydrops, elevated WBC counts with the presence of blasts, predominantly the myeloseries, bruising, skin infiltrates, exudative effusions quite common, respiratory distress, and massive hepatomegaly. Prognostic indicators are the presence of persistent liver function test abnormalities, hepatomegaly, and ascites. So I think we have done this transient leukemia. So hematologically, if you look at it, you will find that there could be leukocytosis and persistent peripheral blast cells, which will help you in making a diagnosis of congenital leukemia, and then you ask for whether it is a Down syndrome. They say that, then you put it as TAM, send it for flow cytometry, and then you get the answers. Cardiopulmonary, I think we have already explained it. So a peripheral smear, which is the bread and butter of all of us, shows the presence of deeply basophilic immature blast cells. The flow cytometry demonstrates M7, and basically bone marrow examination is not a must because you have so much of blast in the periphery, and a flow cytometry would help. So there is no need to subject the child to a unnecessary bone marrow aspiration or biopsy. So the good thing is that if you don't have many of these features, the liver is not much involved, then you can follow it, and then they usually tend to resolve within about 3 months. Those with the high blast count or liver dysfunction may require a low dose cytarabine. Low dose cytarabine meaning 10 to 20 milligrams per meter squared. We actually started ours with 20 milligrams. The good thing is that the TAM cells are very highly sensitive to cytarabine, so periodic monitoring of the CBC is a must. Severe liver disease, fibrosis, and as I told you, presence of ascites not resolving are all associated with poor prognosis. Bone marrow aspiration in a Down syndrome is always difficult because of the presence of fibrosis, myelofibrosis. So always please go for biopsy, and I'm not talking about TAM, in the older children. If you have a Down syndrome, don't do only bone marrow aspiration, go with a biopsy because the aspiration would be very poor in yield because of the associated myelofibrosis. Megakaryocytes always tend to have, megakaryocytosis always tends to be associated with myelofibrosis. The mortality is 20%, and even this mortality is because of the treatment. So they are prone for infections and they are prone for drug toxicity. Usually they die of drug toxicity and infections rather than the disease per se. So as we had already seen, 30% of these children tend to present later up to 4 to 5 years of age with MSR. So this was something interesting which I found. It is important to do chromosomal banding in all children with acute leukemia in Downs, because look at what are the findings that they had found. 24 cases of Down syndrome they had done with chromosomal banding. It is not that there were only 24 cases of leukemia. Wherever there were chromosomal banding analysis, they had taken up that. So 23 had a trisomy 21 chromosome complement. One had a translocation. The type of leukemia which presented include myeloblastic, myelomonocytic, monoblastic, lymphoblastic, and erythroleukemia. Only 3 had chromosomes missing from the leukemic cells. Very unusual. And 16 of the 24 patients had extra chromosomes in their malignant cells. The common were 8 and 21 and 19 and 22 in 4 cases. Chromosomal rearrangements were observed in 9 cases. 3 of the 9 had partial deletion of the long arm of chromosome 6. So what is the learning for us? The cases of Down syndrome, when they present with acute leukemia, need to be reported with high resolution chromosome banding of the leukemic cells. So that is for me a critical take home message. So let us come now to the Down syndrome of the AML or ML Down syndrome. They usually tend to present with about 1 to 4 years of age, 1.8. Most of them are megakaryocytic type, and invariably you will find that they had in 30% of the cases TAN and an antecedent myelodysplastic phase is present in 70%. So how is it manifesting? Manifests as progressive anemia and thrombocytopenia, and this is the case where you probably have to do a bone marrow biopsy rather than analysis. BMA becomes difficult because of the hypercellularity and myelofibrosis. So you will find that majority of the time the smear shows normal cells with dysplastic changes, and then a Triffin biopsy shows dysplasia, increased blast, abnormal megakaryocytes and variable fibrosis. So the treatment is that again 80% of them actually survive because of the highly sensitive nature of the tumor to cytarabine. And the treatment failure that has been seen in 20% is often because of the drug toxicity, presence with severe mucositis and infection. The resistant diseases and relapses are very, very, very rare. So maybe the trend forward would be to reduce the treatment intensity in comparison of AML without Down syndrome, so as to give them that 20% increased survival rate which they would otherwise have. So these are the different distinctive features between the TMD, DS, Down syndrome, megakaryocytic leukemia and the non-Down syndrome megakaryocytic leukemia. So the only thing which I want to flag is that you will have GATA mutation, GATA1 mutation in TMD and DSML, which will not be there in the non-DS AML. Of course, trisomy 21 will not be present in non-DS AML. That's it. Now, a few words about acute the lymphatic leukemia. Again, this is quite common and beyond 5 years, yes. You will find that they are only B cell and not a T cell. T cell is very, very, very rare. And all DS tend to have a hypodiploidy, which is a poor prognostic sign. The cure rate is around 60 to 70%. Which is much, much less than the ALL without a Down syndrome. Again, here they have a tendency to respond to doses of methotrexate in an abnormal manner. They show high toxicity to methotrexate. So I think I will stop with this, and I will thank the organizers once again for having given me an opportunity to go back and refresh my memory and to share with you what we found and a little knowledge of what we have. Thank you.
Thank you, sir. The session is open for the audience for any questions. That was a very in-depth and useful talk on hematological disorders in Down syndrome. So Down syndrome doesn't end up with an abnormal karyotype. It needs regular follow-up later on for any hematological disorders. You have enlightened on it, sir. Thank you, sir. That was a great talk, sir.
Thank you. Thank you. Thank you for those kind words.
Thank you, sir.
Yeah, good talk, Ravi.
Thank you. Thank you.
Thank you, sir. Thank you so much, sir. Any questions from the audience can be asked now. Any queries can be directly connected with me. You can chat with sir if you have any queries. Or you can post it in the chat box also. Sir, you can disconnect. You end up your unmute and.
I think I've unmuted and I've stopped sharing the screen.
Yes, sir. Yes, sir.
Is my screen still visible?
No, sir. The screen is not visible, sir.
No, you have not. You cannot share.
Yeah. So maybe.
Now, I'm here to introduce the next speaker, Dr. Tina Koshi. Madam is a renowned cytogeneticist with a wide knowledge and experience in the department, and she's working in the Department of Cytogenesis from SRMC, and she has a wide knowledge and clinical experience in the field of cytogenetics. We are looking forward for your interesting talk on the cytogenetics of pediatric leukemias, madam. Kindly share your screen. Ma'am, you can start with your presentation, ma'am.
Am I audible?
Audible, ma'am. You can start with the presentation.
Okay. Unfortunately, I don't think I can start my video because it's interfering with my audio. So is that okay?
It's okay, ma'am. The screen is visible and audio is also visible, ma'am.
Right. Thank you very much. So
Thank you,
before I begin, I would like to thank the organizers, in particular Dr. Parvati, for allowing me to be a part of this annual meeting. And I've been asked to speak about cytogenetics of pediatric leukemia. So I think at the outset, I would like to probably celebrate the fact that cytogenetics is still relevant today in 2021, considering that we've moved to the next generation of genetic diagnosis, which is your next generation sequencing. But still, this field of genetics, which started way back in the 1950s, much before many of us were born, still very, very relevant, especially in the field of pediatric leukemia. So,
Madam, sure. Sorry to disturb you. Make it as the full screen, ma'am.
Sorry, it is full screen already.
Wait and see.
Just
No,
one
ma'am.
second. Is it full screen?
No, ma'am. You have to press this one. Yeah, yes, ma'am.
1 second. Is it full screen?
Not it.
Not it, ma'am. Not it, ma'am.
Not yet. Actually, on my system, it's showing full screen.
You can go to slideshow from beginning, ma'am.
Oh.
Slideshow.
Yeah, it is at the beginning.
No, you have to go to the slideshow and then
on the top
ask you
slideshow, ma'am.
option of slideshow, and then just put it as beginning. Then click on.
This is the beginning.
No, you are in the first slide, agreed. But if you go down, there are, or if you go to the slideshow at the top of your presentation, there is an insert design animation slideshow. So click on slideshow. Yeah, click there, and then go to the from the beginning. Just go to from beginning, the first one.
Yes,
yeah, this is the first one.
Yeah. So now it will change.
Okay. Now?
No, it has not changed.
From beginning, you have not pressed, ma'am.
You have to go to the from beginning and then press again.
Is it not moving? Because in my system, it's moving.
Maybe can you? Yeah.
Sorry.
Press F5.
That two side, right?
Yeah. Press F5.
Now?
It's not moving. maybe.
I moved. Okay,
Yeah,
can
I
you just
know.
give me a minute? I'll probably upload it on my Google Slides and try from the tab. Can you just give me a minute, please?
Yeah, sure.
Yeah.
Yeah.
Madam, put cursor on from beginning and click it once.
No, I've tried that, ma'am. I've tried all the other options, but I think there's some system probably.
I think you can go ahead with the presentation like this, ma'am, because its screen is visible, but it's
Can
not.
you, is it now moving? No.
Left upper corner of the thumb.
I'll put it like this. Is it
Yeah,
fine?
I think you should go ahead and present it like this.
Okay, fine. Okay.
Yeah.
So, yeah, apologies for the technical error. Yeah. So why do we have to do cytogenetics? Because in terms of pediatric leukemia, it's largely because even though we already know that childhood leukemia is biologically heterogeneous, it's also very genetically heterogeneous. So which is why we need to be able to do the cytogenetics of pediatric leukemia. We probably know that in terms of pediatric leukemia, ALL or acute lymphoblastic leukemia accounts for around 73% of all the cases, followed by AML or acute myeloid leukemia, constituting about 18% of the cases, and a very, very small percentage. Hold on, I think Dr. Papati. Yes, ma'am. Okay, okay, perfect. Thank you. So, yeah, are the slides moving now? Hello, are the slides moving?
You are in the same slide as what you spoke. Have you moved it to the next one?
It's the third slide.
No, I'm still on the same slide. Yeah.
Yeah.
Yeah, this is the third slide. Yes.
Yeah.
Okay.
Fair enough.
So, yeah, these are the different classifications of ALL. And all three will show a wide spectrum of factors which play a role both in the epidemiology, more importantly, the risk stratification and the therapeutic intervention. So this highlights why we need to study the cytogenetics of leukemia, which is basically just the chromosomal analysis, because more than diagnostics, the cytogenetics actually plays a role in prognosis for both ALL and AML. I'm not going to talk too much about CML in pediatric leukemia because, as you saw in the previous slide, it exhibits very few percentage of pediatric leukemia cases. So I would like to stress on the fact that whatever we have, we're going to study thereafter is basically the prognostic factor in terms of pediatric leukemia. Okay. So backtracking a little and talking a little bit about the basics of cytogenetics. So if I were to look at the human genome, you know that we have 23 chromosomes, which houses the DNA and the genes, right? So if I want to study chromosomes, it's like looking at the chapters of a book. If I'm going to study just one or two chapters in that book, we use a technique known as FISH, which falls under the category of molecular cytogenetics, which stands for fluorescent in situ hybridization. However, if I want to study mutations, as Sir had mentioned in his talk, the GATA1 mutation, I would have to look at the genes for which I need to extract the DNA or the letters from a book. So today's talk is purely on chromosome analysis with a little bit on about FISH. So here we study all the 23 chromosomes. We look at numerical and structural abnormalities. And sometimes in some cases, we would have to depend on FISH to resolve some of the abnormalities that we see in karyotyping, but are unable to resolve. So how do we do this in the laboratory? So basically, chromosomal analysis, as all of you popularly know it as karyotyping, is an in vitro clinical laboratory procedure where we evaluate all the chromosomes of a cell. Okay, so I don't look at just one cell. The minimum number that we can actually look at is 10, and we can go up to 50 or 100 before I can give a diagnosis. So one criteria for me to study chromosomes is that I have to have cells that are capable of cell division. So any cell that is not capable of cell division cannot be used for chromosomal analysis. I think someone's mic is on. Yeah. So when we're talking about leukemia, the most preferred sample is a bone marrow aspiration. Okay, but we also can obtain chromosomes from lymph nodes or solid tumors. Albeit it's a little more difficult to obtain good quality chromosomes for such samples. Now, in most constitutional disorders, like if I were to examine a child with Down syndrome, we would prefer to get lymphocytes, which yes, they are non-dividing, but through a process in the laboratory, we can stimulate divisions in those lymphocytes. We can also look at tissue biopsies, like your chorionic villus sampling in case of suspected cases of Down syndrome in prenatal diagnosis. So these are the range of samples that can be sent for karyotyping. Bottom line, you need to remember, the cells have to be viable because they need to be, we need to stimulate them into the cell division, or we need to arrest cells when they enter the metaphase of the cell cycle, which is only possible in a proliferating cell, which is again only possible if the cells are viable. So coming to when we're talking about pediatric leukemia, the most common sample that we receive is the bone marrow aspirate. We generally recommend that this is collected in preservative-free sodium heparin vacutainers and transported at room temperature within probably 24, not more than 48 hours. And in the laboratory, we generally prefer the first few millimeters of the bone marrow tap because we believe that it consists the highest proportion of cells and therefore translates probably to the highest success rate. So if we do get the second tap, it lowers the success rate of getting chromosomes in vitro. Okay, like I mentioned, beyond 42 hours, the viability of the cells go down. And like I mentioned in my previous slide, we need viable cells for us to give you a report. Without viability, we can't proceed forward. So this is the workflow in a nutshell, and labs that adhere to these workflow very, very strictly will have a higher success rate than those that have not standardized their protocol, right? So very briefly, what we do is when we receive a bone marrow sample, we set up what we call as a culture in the laboratory, which constitutes adding the bone marrow sample to a medium to provide nutrients to the cell. And we also add a metaphase arrestor known as cold-submit. So bone marrow, unlike your blood karyotyping, is what we consider to be a short-term culture. So we can actually harvest metaphase cells within 24 hours or even directly, okay, on the same day. but we generally allow for 24 hours because that increases the success rate. Following the next day, we treat the cells to a hypertonic treatment. This is basically to swell up the nucleus and allow spreading of the chromosomes. And then we fix the cells because we need to get rid of the RBCs, and we need to also preserve the cells. Therefore, we fix it with what is known as Carnoy's fixative, which is nothing but methanol and acetic acid. Then we prepare slides, and this is a very unique way of preparing slides, not like a smear that you would do in pathology. But we basically drop the cells from a height which allows the nucleus, which was swollen with hypertonic solution, to burst, pretty much like a balloon, onto the slide. So it's a very artistic, in a sense, protocol. So if you get it right, you get beautifully spread chromosomes onto a slide. And because we need to be able to identify the structural abnormalities in chromosomes, we subject it to what is known as GTT banding, which gives unique patterns to each of the chromosomes, and then we proceed with the whole step of karyotyping. So I think around 20-25 years ago, when I started out, karyotyping was done by cutting and pasting, printed images of the patient. But now we actually screen slides under a microscope, and we have a system that allows us to capture these images, and an automated system that allows, or software that allows us to do the karyotyping. By and large, we want around 20 metaphases. Now, this may not be possible in all cases of leukemia, so around 10 to 15 is acceptable for us to give a report. So that we have at Ramchandra Medical College. So this is an automated system which allows us to capture the images. There's a camera here into the software, so there's no cutting and pasting of paper involved anymore. Just with a click of a button, you get the karyotype arranged. So it's simplified our life a lot. Okay, so this is just a representative image of a karyotype. I'm sure all of you in the audience have seen one at some point or the other. So this would be what we consider as a normal karyotype. You have all the 46 chromosomes, no structural abnormalities. Like I told you, each chromosome has a unique appearance. So a person who's trained to identify these unique patterns will be able to tell you when there's a variation from that unique pattern. If in this case, for instance, if you see, it's a very, in a sense, a simple structural abnormality, numerical abnormality, where you have more than the 46 number, which is known as hyperdiploidy. This is another example of a karyotype, a translocation 922, often seen in chronic myeloid leukemia, or CML. So the 22, and this is the Philadelphia chromosome that you see here, and the 9 that is involved in the translocation. And we also see deletions of 9, and sometimes we see this in progressive CML, right? So in addition to, the 922, they have now progressed to a deletion in chromosome 9, right? So to summarize what I've just told you right now, we can detect not only numerical abnormalities like hyperdiploidy, but we can also look at structural aberrations like your translocations and your deletions. And as I reiterate, it has strong prognostic importance in risk stratification and in a decisive role in guiding the treatment. So it's very important for us to get the cytogenetics done, simply because it guides the treatment protocol. So the next few slides are just a summary of the numerical and structural abnormalities that you would observe both in ALL and AML. So in terms of numerical abnormalities, a high hyperdiploidy, which we define as chromosome numbers between 51 to 67, we consider this to be a favorable prognosis both in ALL and AML. And we can use your standard cytogenetic analysis or karyotyping to detect it. FISH very rarely is used, but if you do use FISH with multiple probes, you can pick up hyperdiploidy. On the other hand, your low hyperdiploidy, which is defined by chromosome numbers 47 to 50, is considered to be unfavorable, especially in ALL. You can again pick this up with both standard chromosomal analysis, more preferable than FISH. And you have your hyperdiploidy, which we define as less than 46, generally in the range of 30 to 46 or 45. And this again is very unfavorable. especially those which have chromosome counts of 33 to 44 in ALL. Okay, so we generally pick this up again with karyotyping. Your near haploidy, which is between 23 to 29, is considered to be unfavorable in ALL, again picked up with cytogenetics. And you can also see monosomy 7, or the entire 7, or either only 7q deleted. This is also unfavorable in your AML. Picked up mostly with FISH, can be picked up with karyotyping, obviously, but sometimes you can apply another technique which is known as array-CGH. Generally not required, but some people do go directly for array-CGH. In terms of structural chromosomal abnormalities, now these are a little much harder to pick up. Numerical is pretty straightforward, but when we're analyzing for structural, but some of them would require additional techniques to confirm our findings. What is very straightforward is the translocation 821. Okay, this is the fusion between AML ET or RUNX CBFA. This we consider to be a very favorable prognosis in AML. We can pick it up with cytogenetics. You need not always go for FISH, but you can also pick it up in RT-PCR, especially if it's a low clone, as in the number of cells showing the 821 is quite less. Then the sensitivity of RT-PCR is much more than your cytogenetics of FISH, right? So maybe if after treatment, if this was seen before treatment, you would rather go for RT-PCR than cytogenetics. In version 16, another favorable prognosis in ALL. Generally, it's a little hard to pick it up in standard karyotyping. You can miss it. So we would suggest that you offer FISH for inversion 16. Not that we can't pick it up in standard karyotyping, but not as clear-cut as your 821. It's a very subjective analysis. Your translocation 922, again, very straightforward. You need not go for FISH, or you may go for RT-PCR when you're dealing with low clones, but you can pick it up in a karyotype because it's a very obvious translocation. Not so obvious in some of the cases is your translocation 1517. So I would recommend you opt for FISH, RT-PCR if possible, but I would prefer FISH in terms of translocation 1517. There are some cases that we have picked up on standard karyotyping, but I would admit there are a few cases that we've also missed. So that's why I would recommend FISH. It's got a favorable prognosis in the M3 AML. Then the other common one that we see is the any rearrangement involving 11q, either as a deletion or as a translocation. So this is unfavorable in ALL, intermediate to adverse risk in AML, right? Generally seen mostly in AML. More often than not, we do not pick this up in cytogenetics unless it involves a considerable translocation. So I would recommend that you opt for FISH for the MLL gene if you're looking for 11q rearrangements. Another few ones that we see very commonly in laboratory is your translocation 1221, or known as the TEL-AML fusion. So this is considered to be favorable. We do not pick this up by and large by karyotyping. So your first level of investigation will be FISH or RT-PCR, right? Your translocation 119 is actually, you can either pick it up or you may not pick it up in standard cytogenetics. We have picked up quite a few in standard cytogenetics, but some we've missed. So I would recommend either doing FISH directly or just do cytogenetics. Doing FISH directly or cytogenetics, your standard karyotyping with FISH, right? And then finally, your 1011, sorry. Again, one of the translocations involved in 11q23. This is considered to be unfavorable in AML. Okay, so this is just a very short summary. Of course, there are other abnormalities associated, though to a less frequency than what I have listed here. Okay, these are additional recurrent structural abnormalities that you may see, like the whole HOX-X TLX, which is the 514 translocation. This one, the NUP19 abnormality, and the 6q deletion, which I believe Sir also mentioned for Down syndrome. So this is present in 11% of pediatric cases. So you might end up finding up these structural abnormalities incidentally when you're doing a chromosomal analysis. Also, your 9p and 9q abnormalities observed approximately in 7 to 12% of childhood ALL, and your translocation 122, which is restricted to your AML M7. Okay, so just recently also we saw one with the translocation 122. So just a few images for you to understand that, yeah, it does become a little difficult for us to see sometimes and not so difficult in other cases. So this is 821 translocation, quite obvious because the 8 here is much shorter than its homologue, and the 21 here is much longer. So it's fairly easy to detect this in a karyotype. Similar to that, your translocation 119, like I told you, we can pick it up in cytogenetics. You need not go directly for fish. But if you were to do fish, you would miss out on abnormalities that are additional. Like in this patient, there was a isochromosome 9 as well as a marker chromosome. So if you were to do fish, you would only pick up the translocation 119, and you would not pick up the additional translocations or rearrangements. So this is an unbalanced translocation of 922 along with a derivative chromosome 19, which is a result of a translocation between 1 and 19. So the reciprocal is lost, and what has remained is only the part of 1 on 19, and there's a 922 translocation also. Just want to highlight here the number that you generally see here in all reports would give you the information of how many cells we saw this abnormality in, or how many cells that we have analyzed in that particular case. So this is also a fairly rare than that we see the isochromosome 9. Okay, that we observed in a patient with ALL. So isochromosome is defined as a chromosome in which it loses one arm. For those of you who are not aware, every chromosome has two arms, the short arm, which is known as a P arm, and the long arm, which is known as a Q arm. So when we define an isochromosome, it's defined as a chromosome in which it has the presence of two of one arm and none of the other. So in this case, it is an isochromosome 9q, where it has lost the P arm and gained another Q arm. Now, what happens when we see something like this? Okay, so I can only, in a very subjective analysis, I can say that probably this is 11-19 translocation, but I can't say with 100% surety. That's why sometimes you may get reports where there's a query mark in front of the designation. This implies that we are assuming or hypothesizing that there's a translocation 11-19, but we can't be 100% sure, right? So that's when we rely on FISH to confirm or to refute our hypothesis that there is a 11-19 translocation. And using the MLL break apart probe, we were able to prove that yes, there is a 11-19 translocation. So this is known as a complex karyotype, right? So sometimes we do come across karyotypes that we can't really resolve, okay? And it's defined as the presence of 3 or more cytogenetic abnormalities in the bone marrow aspirate, but does not include inversion 16, translocation 16-16, translocation 821, and the translocation 15-17 as defined by this group of people. But the MRC also defines it as any karyotype that has 5 or more chromosomal aberrations is defined as a complex karyotype. And sometimes standard chromosomal analysis is not sufficient for us to resolve such cases, and that's when we depend on molecular cytogenetics. So there are actually 2 techniques that come under this category. One, which I've mentioned before, is FISH, but you also have something known as chromosomal microarray, which is available right now. Not very affordable to a lot of patients, but still available for those who can. So molecular cytogenetics is a powerful adjunct to conventional standard chromosomal analysis. And another advantage of your FISH is the fact that you don't really require metaphase chromosomes. Any cell that has a nucleus is good enough for you to do a FISH analysis. So that increases the success rate of us delivering a report, whereas a karyotype, which largely depends on the presence of metaphases, if you don't get metaphases, you unfortunately cannot give a report. The other advantage is that you can use it to archive tumor material, which, as I told you earlier, we can't do a karyotyping because you don't have viable cells in a archived tumor material, so you can't proceed with karyotyping. It is very accurate and specific, which is both an advantage and a disadvantage. Accurate and specific because it will give you correctly yes or no to the question that you're answering or for what you're fishing for. But if you see in the previous examples that I've given you, it will not give you any additional information. So it only give you information for which the probe is designed to give you. So for those who are new to this term of FISH, just a brief introduction on what is FISH. It's a technique which is used to detect the presence or absence of a specific gene sequence. Not only presence or absence, any alteration with those gene sequences can be picked up, like the copy number aberrations, whether there's a deletion, whether there's an amplification, or even if that region is translocated onto some other chromosome. All this can be picked up with FISH. So this is the overall view of what happens in FISH. You have these DNA labeled probes. A DNA probe is nothing but the oligonucleotide sequence, which is complementary to the region that you want to study. And in order for us to track where it's gone and bound, we use what is known as a fluorescent label or a fluorochrome. So the procedure involves denaturing the target DNA. The target DNA is one which is fixed onto a slide. And then you also denature your probe, and then you allow them to hybridize. Hybridize is nothing but a complementary base pairing of the target DNA, which is basically a patient sample which is fixed onto a slide, and the DNA probe, which was added onto the slide. Following a procedure of washing and then detection, you'll then be able to see whether your probe is actually hybridized to your cell or to your chromosomes. Where has it gone and hybridized? And therefore, the interpretation is dependent on the type of probe that you're using. So in general, each fluorescently labeled probe will either give you two signals. We use the term signals, which is nothing but, you would see it as two dots on a nucleus or two dots on a chromosome. If you see two, that means it's a diploid number, which we consider to be normal. Anything more than that, we call it as a duplication or an amplification. If you don't see the dot or the signal, you would interpret it as that there's a loss of that particular region in the chromosome or in the nucleus. So like I mentioned, interpretation is largely dependent on the type of probe that you use. So you have unique sequence probes, which are also known as LSIs or locus specific probes. We use them not only in hematological malignancies, we can also use it in constitutional disorders like microdeletion syndromes. We have another category which is known as repetitive probes. These are DNA probes that are used to recognize areas that have repetitive sequences. Examples is your centromeres and your telomeres, which are basically the ends of the chromosome. What is of relevance to leukemias is the gene fusion probes, like, for example, the translocation 922. So this will allow us to identify the fusion of BCR and ABL, which can also be picked up with a karyotype, but this is a lot sensitive. We also have break apart probes. Okay, so we use this in 11q23 rearrangements, where the MLL gets either translocated to other chromosomes or they get deleted. The third or last category is the whole chromosome painting probes. This is used to literally paint the entire chromosome. So we don't really use this in diagnostics, but there's a lot of use of it in research which involves, for instance, radiation genetics. So this is just an illustration of what I've mentioned. So here you have a normal diploid pattern in a translocation split apart. You will see two normal signals for the normal chromosome, and then the chromosome that gets split apart. Again, if it's together, you should see it as a yellow signal, but if it's split apart, you will see a green and a red split apart, right? So I'm not too sure if these images are very clear, but overall, I think you get the message that depending on the type of pattern that we see, we interpret the aberration as such. So yeah, so this is a clearer image, I think. So here you have the MLL fusion, but what you also see is 3 copies of the MLL fusion. So we would call it this as MLL amplification. In this image, you see the TEL deletion. So we were looking for a TEL fusion, TEL AML fusion, but instead what we got was a TEL deletion in one cell, whereas the fusion was present in the other cell, right? And this is the MLL deletion. It's all using the same probe, but depending on the interpretation pattern, you either look at it as an MLL break apart, but all what you see here is an MLL deletion. Okay, so that gives you also additional information. So just to summarize what I've just told you, that there's a choice that you have to make as far as the FISH probe is concerned. So unlike karyotyping, as a doctor, if you were to order a FISH test, you have to be very specific in your request form, because we choose the probe depending on what you have requested for. But in karyotyping, all you have to write is, I want a karyotype done. You need not be specific about anything in that sense. So we have to decide the probe based on what type of cancer we're looking at, or what type of rearrangements have been reported in that cancer. So there are different types of probes. You have dual color break apart probes that can look at chromosomal translocations. Your fusion probes also look at translocations. And then you have something known as MFISH, which actually has not developed as much as we would have liked to because of the cost factor. But this is a 24-color karyotyping, which allows us to look at different regions of different chromosomes, and is especially useful in these three areas where, the translocation of telomeric ends of chromosomes, or suppose you see a marker chromosome. For those of you who don't know what a marker chromosome, it's basically unidentified chromosomal material. So if you want to determine its origin, you can use what is known as a 24-color karyotyping, or MFISH for short. And also in terms of unbalanced chromosomal translocation in a complex karyotype, we can make use of MFISH to resolve all those kinds of queries. So this is an example of an MFISH. As you can see, unlike the other fish that I showed you, where it just showed you dots, in MFISH, by use of an algorithm, it's a software basically, we can color all the chromosomes, right? So, it's understood that when you use colors, you can identify rearrangements much easier than if you use black and white images, right? So here, if you can see, there's a complex karyotype, which would have taken me probably a long time to resolve in a karyotype, and I still would have not been very sure. But in a fish image, I can see a purple and a blue and a green, and I can see, okay, this is green, there's a purple here, and there's a blue here. So then I can resolve which chromosomes are involved in this complex karyotype, right? So it makes our job a lot simpler. But unfortunately, like I told you, it didn't take off very well because of the cost factor. So we only do this in very extreme circumstances when it's really required. The other application of FISH is in post-transplant, especially if it's gender mismatched. So we can track the number of circulating lymphocytes that have the donor cells, right? So in this case, this you can see this is 24 hours after, or sorry, a few days after post-transplant, and you can see both clones, both the male and the female. And then in most cases, we keep monitoring at 6 months, 1 year, and based on the proportion of the donor cells, we can determine the post-transplant success. However, I reiterate, this is only possible in cases of gender mismatched bone marrow transplant. We can't do it for the same sex bone transplant. So yeah, but when you depend only on FISH, what happens is you miss out on additional abnormalities that you detect in a karyotype. So this slide tells you that, okay, you had a successful transplant, but you also had other cytogenetic abnormalities that you would have missed out if you depended only on the FISH results, because in FISH you were looking only at the sex chromosomes. So here you saw an additional abnormality that could in a sense impact probably prognosis of the patient, even though the bone marrow transplant would have been considered successful because you're seeing a great proportion of the donor cells. So what I want to highlight by that slide is that there are differences in the utility of karyotyping and FISH. You can't really depend on one technique. Sometimes you need a combination of both to get the overall picture for the patient. So this sums up the differences between the two techniques. In karyotyping, you have all the chromosomes are screened. So in a sense, you're looking at the entire genome. You can rule out clonal evolution. You can examine different types of clones, and you can actually, through the translocations or the arrangements, you can actually also determine which genes are involved in the tumorigenesis by backtracking and finding which genes are located in the loci that are involved in the rearrangement. FISH, on the other hand, although it's extremely specific test, if I'm looking for a translocation 922, it will tell me yes with 100% certainty that it's there or not. It does not screen all chromosome abnormalities, so you only get information on the region or the abnormality that you're looking for, which makes, you might end up missing out on things that could have been relevant to the prognosis, but you missed it because you were focusing only on one kind of abnormality with the FISH. So I think that sums up my talk. Thank you very much for your patient listening, and I apologize for the technical errors. Again, thank you to all the organizers for allowing me to be a part of this event. Thank you.
Thank you, ma'am. That was an extensive and wonderful talk. And thank you for sharing your interesting cases and enlightening us on cytogenetics of pediatric leukemias, and also educating us on the interpretation of FISH images, ma'am. Thank you, ma'am. Thank you so much. And any questions from the audience can be posted up, or you can directly ask madam. Madam has got a wide and extensive knowledge in cytogenetics, and she has got a wide experience in cytogenetics. So I request all the audience to utilize this opportunity to ask any queries to Madam directly, or you can also post in the chat box. We have not received any. Good morning, all. Welcome back to the session. Now I'm very honored to introduce Dr. A.K. Munirajan, sir, PhD, Professor and HOD, Department of Genetics, University of Madras, Taramani. Sir has undergone fellowship programs in various institutions from various countries. Sir has undergone postdoctoral fellowship programs at various renowned institutions from various countries. Literally, he has done a world tour, and he has presented so many papers and journals in national and international publications. I welcome you, sir, to deliver your speech on overview of genetics in pediatric cancers. So kindly share your screen, sir.
Yeah, coming.
Screen share. Sir, you can start with your PowerPoint presentation, sir.
Yeah, 1 minute, I'm coming.
Thank you, sir.
So, does it get shared? You get to see that sharing?
Yes, sir. Screen is shared, but we want you to make it as the full screen, sir.
Yeah, let us see how whether it goes fine. Fine?
Yes, sir.
So just see the transition is happening nice.
Yes, sir.
Okay. Okay, can I go ahead?
Yes, sir. Thank you, sir.
Somebody is waiting, it seems, 4 people.
Yeah, but I'll to see to it, sir. Thank you, sir.
Yeah. Okay. So thank you very much. I think I'm very happy to share the overview, and after giving an overview, I'm going to share that a neuroblastoma, research work on neuroblastoma, and coming to the an overview of pediatric genetics. I'm Munirajan from Department of Genetics, and what is that? Transition is not happening. Okay, so when you define a cancer, essentially because you wanted to do the genetic overview, and you could ask, is it truly genetics? If you look at the cancer, most of the adult cancers are going to be mostly somatic. But if it comes to pediatric, many of them will be having a germline also. So I'm going to give you the list of things where it is germline and where it is somatic. So it is going to be caused by changes in the genes that control, like you have the normal genes. It is essentially a loss of control in cell cycle. So the cells will be normally progressing and dividing and growing. And when this control is lost, it is going to be the cancer. And essentially, there are two kind of forces that controls the cell division. One is the positive regulators, another one is the negative regulators. The positive regulator give the switch to cells to divide, and negative regulators could be putting a brake to the cells when the things are not going right. So if in this case, you can define the positive regulators as an oncogene and negative regulators as a tumor suppressor gene. So when it comes to the cancer, so normal cells, this is the squamous cells. If you see the normal cells and abnormal cells are coming, and this abnormal cells multiply, and then after multiplication, it started even acquiring independent characters and try to invade the surrounding tissue and grows its own blood vessels, and slowly it becomes a cancerous. So how this is progressing is kind of mostly through the selective mutations, mutation 1, mutation 2, mutation 3. Not necessarily always mutation. Sometimes it could be also deletion, duplication. All those things are also going to be there. So I will be showing one example each, and then giving you the overview. And in this case, what are all the type of pediatric tumors? I think, as you are aware, like there are solid and the blood. And leukemia and lymphoma is going to be the blood disorders, and brain, neuroblastoma, and sarcoma and Wilhelm's tumor are the major pediatric cancers. And then if you look at the distribution of childhood cancer, most of them, the right corner, the ALL, acute AML, and non-Hodgkin's lymphoma, and Hodgkin's lymphoma in this group. And then you see the brain 16%, neuroblastoma 17%. And I'm not sure about in India, maybe someone could highlight me, like what is the percentage of neuroblastoma in India, Wilhelm's tumor, and rhabdomyosarcoma, retinoblastoma, osteosarcoma, Ewing sarcoma, and all other cancers. So these are all the type of pediatric malignancies, what is commonly observed in the cancer. And this data is not Indian data. And I'm sure, like you might be knowing, I'm not an expert in the line. So I just collected this data from the US resources. So common genetic events, you might be asking, sir, what is the driving force that makes this cancerous? So we have seen that mutation. So most of the time, a mutation could be a somatic. That means it's going to happen only in the somatic tissue. And germline, and many of our pediatric tumors have a germline basis and also spontaneous background. So both could be there in with reference to the point mutations in pediatric tumors. And gene amplification, you can very well know when you say gene amplification, MYC amplification is going to be the commonest one in NMYC amplification is going to be the commonest one in neuroblastoma, and deletions and duplications and gene fusions. So this is the latest about all the pediatric malignancies reported in the world. So you can see the mutations. This panel is about the adult cancer, and this panel about the pediatric cancer, and again the adult thing. And if you look at the mutations, this is the median. What is drawn is the median. And this is the coding mutations per megabase mutation. So in this case, if you come to the pediatric tumors, you are seeing that very high mutation in pediatric tumors. So osteosarcoma, and then this one, and all these things are going to be like pediatric high and hypermutators and then ultra mutated. So essentially in this case, so you tend to see the mutation, and all the list of this abbreviations are here. So what is the individual things are going to be mutated. And then coming to the germline, so you might be asking, is it possible like all of them were germline? Yes, they do. They do have a germline basis. And if you look at the number of, for example, this one lists the proportion of sample with the mutation, and then it is listing all the tumors. And also by means of deletion, duplication, deletion, and SNV, single nuclear variation or insertion deletions, this one. And if you look at the distribution, it is also the p53 mutation seems to be very high, and the number of patients with the p53 changes, be it deletion, duplication, all the things, all cancers were given in the different color. And if you look at this, p53 was very common, and BRCA2 and LRs. So all these things were found to be very common. And normalization for cancer types and prevalence. And then in 60% of cases, there is a predisposition to cancer. So remaining were the spontaneous mutations. So in this case, the number of cancer types, if you classify them, what are all the type of genes or group of genes involved in cancer? So what is the cellular process that is disturbed? I'm going to list all the table, list the process and the genes. I'm going to list it. So this is the overall picture showing the DNA repair related genes are going to be one group, check2, MSH2, TP3, BRCA2, MSH, PMS2. This group of genes are going to be a DNA repair, and then the transcription, VHL1 Epil syndrome, P53, and then other the pathways, epigenetic modification, MAP kinase and PA3 kinase, transcription. All these cellular pathways, also pathway mutations or germline mutations, are also causing the disease. And then with reference to the mutation, so we have done all the time mutations. So I told you that there is also amplification as well as deletion is also happening in the cases. So in this case, this is the deletion and duplication are going to be maybe most of the time it could be termed as genomic instability. It could be an insertion, it could be a deletion, it could be a translocation, it could be an inversion. So this is the general structural number of structural variants present in the different tumors. And then with reference to the p53 mutation, somatic mutations in this much, and germline mutation, even Lee-Fromme syndrome, it's going to be one allele of the p53 is going to be mutated. That is called Lee-Fromme syndrome, that makes the individuals carrying one allele mutation prone to developing cancer. So with reference to the amplified and deleted regions in the pediatric tumors, so you can see that the 1q25.2 region is amplified, 1q43 is amplified, MICN is amplified in the neuroblastoma, and GALI2, AVR2, and TET, you know already, telomerase enzyme. If that is going to be amplified, that keeps the cells uncontrolled proliferation. That means it offers the cells to divide uncontrollably, and that is going to be amplified, and that is how maintained. But some of the normal cells are losing the ends, the telomere ends, and also the enzyme activity. So after a certain time, they attain the senescence and stop dividing. But the cancer cells attain this immortality by means of amplifying the TET enzyme. And BRAF is also amplified, and MIC amplification is common, and 8q22 this region, and 19q22 point region, OTX2 gene, and also all these the red ones are going to be the regions amplified, recurrently amplified in cancers. And also if you look at the deleted regions, 1p36.13. So I'm going to talk about this gene at a later date if I have a time. And I'm going to talk about the 1p33, a tumor suppressor present in this region, how the deletion of this region is resulting in neuroblastoma. That I'm going to present a detailed work. And then all the P10, patch1, and CDK, the cyclin-driven kinase, and all these things are deleted. So these are all the way by which generally overall picture of the genetic changes like amplifications or deletions responsible for causing the pediatric malignancy. And So this one was completely analyzing the whole genome, and then they were able to pinpoint what is the so by means of studying. So this is the whole genome study where the unbiased manner they profile the all the gene expression by RNA sequencing, and then plotted the expression level and the increasing number of cancer types. And what you can observe from here is the SNV CNV is sometimes more in some cases, and mutations is going to be also very more in cancer. Sometimes both are present and none of them are present. So you have a gradation of changes, genetic changes present across the tumors. And then what they found out by analyzing or subgrouping this expression pattern, they were able to identify what are all the signaling pathways that is affected and where that could be targeted. For example, MAP kinase signaling is across the tumors. It is affected, and transcription, cell cycle control, PI3K, AKT, mTOR signaling pathway, RT receptor tyrosine kinase signaling, DNA repair, other kinases, and puberty regulation, telomere maintenance, not signaling, and NH signaling. All these things are going to be, if you know where the mutations are, the genetic changes are going to be present in any of the cell cycle component, then you could have a drug targeting that. And then coming to the gene fusion, you're all aware that even all the cytogenetics people would have given that the gene fusion, the commonest gene fusion is the translocation, BCR-ABL fusion. What is happening in BCR-ABL is this the ABL kinase is brought under the promoter that is constitutively active. That means this ABL is going to be expressed in unrestricted manner. So that too much of positive regulator is going to offer the growth advantage for the tumor. So they start growing uncontrollably. And you know already, like the drugs are the tyrosine kinase inhibitor drugs were there, and it is targeting the they were already known targets, and they were shown that it is working wonders with a certain group of tumors where the this common translocation is common. And then there is another translocation or fusion is happening between the IGH and MYC, and IGH is going to be often continuously expressed, and bringing down the MYC under this IGH promoter is going to make the MYC uncontrolled expression. So there are one possibility that MYC region could be amplified so that they could be overexpressed. Another way, MYC could be also fused with the already constitutively active gene, and thereby MYC becomes very active. So exactly what are the changes happening? Like you might be seeing this most of the time with reference to the fish. You can identify that if you put a BCR and ABL, you see the combined signal indicating that they are fused. But if you look at exactly what is going to be the fusion, and you can see the region where the breakpoint is happening. So in this, up to this region is exchanged with this region. So finally you get a fusion gene that is going to be a protein with 210 kilodalton, and that is going to be a constitutionally active tyrosine kinase. So the tyrosine kinase are going to be activated by means of other mechanism, upstream mechanism. But in this case, they become constitutionally active, and that is giving a growth advantage for the tumor cells to grow. And then the same thing, MYC, exactly what the exon it's going to be spliced, and that is what exactly you are looking at it, exchange. And then I told you like various biological pathways are affected. Most of them, the genetic mutations or the variants present in these pathways are affecting the predisposing to pediatric tumors. The collagen chain polymerization COL7A1 is responsible for neuroblastoma, Williams tumor, and cytoskeletal addition and signaling. And you can see the gene and the tumors, and DNA-based excision repair, DNA double strand break ERCC2, and DNA double strand break BRCA1, BRCA check 2, and then NBN1, PALB2, and everything, whatever the abbreviations, you can see that all the cancers were shown to be predisposed with the genetic variants or the mutations present in this pathway. And then DNA mismatch repair system also going to be responsible for the MSH2, MSH6, and PMS2. All the mutations present in these regions also going to cause CNS tumors, Williams tumors, osteosarcoma, and other Ewing sarcoma, all those tumors. And then DNA repair pathway and Fanconi's anemia, you are all aware that, and RAD51, REC QL41, and genome stability and regulation, ALK mutation. This is particularly familial and sporadic neuroblastoma, and already the drug targets were developed against this, and ATM, RB1, and so retinoblastoma, you're all aware that the classical Knudsen 2-8 hypothesis, simply a clinician following the tumors and the pattern of inheritance, he is able to propose that the inheritance of retinoblastoma is following a classical 2-8 hypothesis. That means only if both the genes are mutated, they are going to be causing the cancer. So that was the success of Knudsen, and he went on to propose the Knudsen hypothesis. And now there are emerging concepts like need not necessarily be classical tumor suppressor. Sometimes even loss of one allele, deletion of one allele or mutation of one allele is enough to cause the disease also. So that is also now emerging, that haploinsufficiency. That is a new concept. It is coming up in the literature. And Irving metabolic pathways and protein interaction and protein translation, and particularly this translation and modification. Remember this KIF1B beta. I'm going to talk about little bit more about this gene, and we were the first to identify this as a tumor suppressor gene. And this is a familial NB. So when we were working, another group reported that there was a familial mutation happening in the germline mutation, predisposing to neuronal tumors. So that was one reported, and red signaling, and then and also now you could ask, sir, is there any syndromes or pediatric syndrome that is associated with pediatric tumors, and the frequencies of the syndromes reported in the cancer and with the genetic syndrome? You can ataxia and ATRX syndrome, Ballard-Gerald syndrome, Beckwith-Wiedemann syndrome, Bloom syndrome. You can see that, and then the genes responsible here in the something dicer. This is the actually this is a protein involved in the miRNA maturation. That means miRNA cleavage. Dicer is going to be an enzyme responsible for cleavage of the primary transcript, and dicer and DROSA cleaves the primary transcript into a microRNA, mature microRNA is coming. And if there is a defect in this dicer, it can also be result. So we are working on microRNA. That's why I could able to give you the detail. And then Fraser syndrome, Rowling syndrome, Kabiki syndrome, and Lee-Fromme syndrome, and MEN1, Mulliveri, and Noonan. Noonan, you are already aware that Noonan is NF1 also. Even RAS is also mutated, neurofibrinosis to NF2. So all these syndromes, associated genes were also predisposing to pediatric tumors. And then the syndrome continues. So Tarcott syndrome, Vagus syndrome. So you might be, you as a clinician, you might be coming across one or two syndrome. This PI3K CA related segmental overgrowth. Even there are mutations in PI3K. Instead of resulting in cancer, sometimes it is a unilateral growth. Only one arm is becoming very big. One side of the body is becoming very high because it's a mosaicism and
இருங்க, call பண்ணுங்க. Excuse me, sir. The audio is not audible, sir. Sir, you can resume your presentation, sir. Sir, unmute yourself, sir.
Okay. Video also you want to share? Okay.
Everything is okay, sir. You can continue with the
Okay. So this is a new consortium plan to study the childhood cancer, and then this is the study cohort, and then the median age at which the diagnosis was done, and then the number of tumor samples analyzed, the male, female, unknown sex ratio, and the targets. And then if you look at the distribution based on the expression, you can see that based on the genetic changes, they are truly clustering. Each one is clustering uniquely. There is no overlap. The neuroblastoma is clustering in one domain, and the Wilhelm's tumor. So this shows that each tumor is unique, even they don't share much across the difference. And that is the outcome of the gene expression network and analysis. And then so we are also like understood that the gene amplification or overexpression of genes also could be there. So this is the one like showing the cDNA, or the you could do the cDNA microarray, or even you could do a RNA expression, unbiased RNA sequencing, and based on that you can plot it and find out the resistance and sensitivity. And you can see that the resistant individuals are all of them, these regions were blue, and all these the regions, when they are blue, they're resistant, and when they become red, they are sensitive. And the same thing is opposite for a few genes like 1 or 2, 3, 4, 5, 6. These 5, 6 genes, if it is going to be the, if you say the red is overexpression, the overexpression is going to be associated with the resistant, and underexpression is going to be associated with the sensitivity. But with the other, the majority of the genes, the overexpression could be making them sensitive. So this could be a pathway targeting. So you can see the change, the overall the transcriptomic profile. If you look at the tumors and between the when it clustered, you can see that there is a group of tumors where you could find out one pattern of expression, and this is going to be another pattern of expression, and this is going to be one pattern. So this is the kind of profile. So now people are going for integrated analysis, and then transcriptome based approach to identify the co-expression modules in the plasmid. And this is again transcriptome based co-expression modules in pediatric tumors. They were able to identify the genes co-express, for example, BRAF, ARIDA1, KRAS, and chromatin, histone modification, mRNA modification. All these processing are very common in AML and ALL. And this symbol indicates that potentially druggable targets, these things are going to be, especially neuroblastoma, the AL kinase were druggable target. And ALL, in this case, B cell activation, differentiation, regulation, all these processes are involved. And if you look at the things like the gene expression profile, pediatric cancer genetic alteration, and co-expression network, for example, in MBL, OTX2 and ZIC1 is going to be indicating a prognosis. And the same way in AL, these three genes are going to be indicating, and AML, the three genes are going to be this, the PRAM1, MYO1, and another gene. And the same way VDJ recombination and wild type WT and NEBL neuroblastoma. So all these co-expression networks. And now previously we were studying one by one. Still, even one by one is going to be useful. And if it is going to be like amplification or specific mutation, you can target that pathway. But now the technology reached a level So you could even analyze everything and integrate all the data and find out the co-expression network, and then identify the pathway that is these deregulated genes are involved, and then where you could effectively design a target and target that particular pathway. So the next slide. So the best strategy for clinical management of pediatric tumors, so integrating histology with genome profiling and patient history will refine the risk assessment and optimize the selection of therapeutic strategy, and ultimately improve the patient outcome. So what the development once when I was a student, like I was just analyzing a p53 mutation and RAS mutation, but now we can analyze the all mutations present in the tumor. And also previously the tumor normal contamination will be technically a challenging one, and the advent of the next generation sequencing, even you can pick 5% of the tumor sample or 10% of the tumor sample is there in the sequencing reaction, still you can pick up the tumors, and a clonal variation can be easily identified by the next generation sequencing. And with this background, like what is the kind of development is coming through, the sequence variant that is going to make them susceptible or responsible for causing cancer, and then identify the mutational signatures present in the particular tumor, and then the structural variant that is common between, and also the germline variant that is going to be there, and epigenetic changes, the methylation in the chromatin modifier, changes in the genes playing a role in the chromatin modification is also a bigger role. And few gene fusions, already we know that in certain cases the gene fusions are mostly in solid tumors, you have more gene fusions. And expression, so gene expression, either the cDNA expression is only relative, and now for absolute expression we are going to be sequencing in unbiased manner all the RNA transcript, and through the transcript we can identify the pathways that is regulated, and then also you can identify the copy number. So I didn't get into the details of techniques. For example, copy number, most of the time you cannot identify the larger copy number variation in the all the next generation sequencing. Still you need to go for classical comparative genome hybridization, either chromosomal array, chromosome based, or now chromosome based CGS is replaced with array based CGS, because that is the coverage is more, so you can particularly focus on that region. So now the copy number variation also could be responsible for deletion and amplification. If you can identify, that could be associated. So with all these things you are going to make a diagnosis. So this is the profile the tumors are carrying, and then based on that you can refine the diagnosis, define the target, and also predict the toxicity. In addition, the toxicity component is not yet explored in detail in cancers, but certain genetic diseases or even non-communicable disease like a CAD and vascular diseases, the metabolism of these drugs and their kinetics and dynamics so well, and toxicity prediction was done, and based on that you can even do the treatment, modulate the treatment. So all the germline, all these changes could lead to a refining the diagnosis, not like before. Even you combine with the pathology and molecular profile, and then say that if this pathology is overlapping with this profile, they are going to indicate a poor prognosis or better prognosis. So that's going to be a refined diagnosis, defined target. So if you identify a certain co-expression network is present that is driving this pathway, then you target that pathway, then easily you can do that. And then the next thing is the germline one you can do. If suppose if you identify this germline variants are responsible, you can go back to the parents and you can analyze the siblings, and then identify the family and advise them you have a chances of getting do the family screening, and tell them that you have a chances of getting, or you are being predisposed to cancer, and then advise them to go for screening the genetic variant, and for frequent screening to keep them under check, like there's no risk of developing things. Or even if you have a risk of developing, you can try to understand the genetic variants present in you, and then you can follow up you can go for follow up, so that it can be detected early. And most of the time the cancers detected early carrying a very less number of mutation, less aggressive, so it may be easier to treat, and it might be completely able to cure them. So that is the possibility. Like if you can do a germline variant and do identify the germline variant responsible for this predisposition of this cancer in that particular individual, then it's easier to target them. In addition, the relapse, the after the treatment, there's going to be like sometime they are not responding and come back, the tumor is come back, and again you perform the same analysis and find out what is went wrong, whether there is a change in copy number, any new sequence variant appeared, any new mutation come in, or any additional structural variants, like some other gene is deleted, some other gene is amplified, that is providing resistance to a drug, or some other gene responsible for sensitivity, and that is getting lost, and that's how they become relapse. So all these things can be further downstream analysis can be done, and by this integrated model you can improve the clinical process. This is becoming the reality, not yet in our country, but in outside they can take a sample and subject it for whole exome or whole genome sequencing, and do RNA sequencing and profiling everything, and then get back to the patient within 3 to 5 days and decide based on that. You refine the diagnosis and define the target and give the drug based on that. There is a potential to cure the patients as early as possible. And then the current challenges for precision medicine. So it may be easier if the pediatric tumors, definitely they have a genetic basis, and could be susceptible, or a few variants could be predisposing. So then naturally we should able to precisely design the medicine for pediatric cancer. The most potential therapeutic targets have not yet been functionally validated. And the pathway. Am I audible? Hello?
Yes, sir. Audible, sir.
Okay. So because I was through my cell phone connection, I received a call. That's why I want to
Yes,
make
sir.
sure.
There was
Okay.
an
So
interruption,
the
but now
most
it's okay.
potential therapeutic target. Okay then. Okay then. Most potential therapeutic targets have not been fully validated, so that needs to be done. And the number of genomic targets is much higher than the number of targeted agents. So that means because we are able to globally profile, we get so much of targets, and we are yet to have agents to target that pathway. And there is an urgent need for better screening methods for early detection and prevention, because this will open up a new avenue. So we need to develop more. And there is a limited understanding of the genomics of relapse and metastasis. Even though we are able to identify a few difference between the primary tumors and the secondary tumors, but still very difficult to pinpoint, because it's maybe a cooperation of multiple genes. So this domain needs to be explored in detail to identify or pinpoint the few definitive causes that could be indicative. And then there is a limited understanding of the germline predictors of toxicity and poor response. So not the genetic variants present in this one not only responsible for making them susceptible or resistant to a drug. It can also make the individuals having a toxicity. For example, if there is going to be any mutations present in the CYP enzyme, that is going to detoxify all these compounds, the foreign compounds what we are introducing. If there is going to be a defect in them, then it could lead to a toxicity, and then poor response, And even instead of cancer killing, this drug even might be killing them. That is also going to be a problem. So all these challenges are going to be once it is opening up, the next generation sequencing is open up so much of challenge. You get a lot of target, you get a lot of interacting networks, and how we are going to target them, and what are all the drugs development, and all these are going to be the challenging future to make the medicine precise for that one individual based on their genetic changes or genetic variations. Thank you. And I think I wanted to introduce another. So this one, you are sharing this. You are able to see this one. Could you please tell me?
Sir, which one, sir? Your last slide only is viewed, sir.
Oh, that means I have to share this one then. Just a minute. Okay, so I just want to introduce that neuroblastoma. So this one, see, before now it's shared, right?
Yes, sir. Can you make it full screen,
So
sir?
yeah, so before getting into this job, I was working on the Chiba Cancer Research Institute, and where I was trying to identify a new tumor suppressant. I showed you there is a germline mutation in KIFN beta, right? Neuroblastoma. So this gene, this particular region is always deleted in various pediatric malignancies, especially in neuroblastoma. So my job is to find out the tumor suppressor present in this region. So the neuroblastoma, already you are all aware that one in the primitive sympathetic neuronal, so parasympathetic nervous system, the mutation, the tumors arising from the parasympathetic nervous system is going to be the neuroblastoma. And etiology is unknown. There are two different phenotypes. One is favorable, another is unfavorable. The favorable phenotypes are going to be mostly aneuploidy. They are near diploid with the whole chromosome gains, very high expression of TRK and neurotropin receptors, and generally it develops before 1 year. Before the infancy, it develops in infancy. But the unfavorable tumors were carrying the 1p, 1p and 11q deletion, unbalanced gain of 17q, MICN amplification, TRKB expression, and invariably the age is greater than 1 year. So these things are going to be the difference between a favorable and unfavorable tumors. And also in the favorable tumors, they have a tendency to undergo spontaneous regression by way of differentiation or apoptosis. This is very common in neuroblastoma. So to show you the neuroblastoma, the favorable neuroblastoma phenotype is going to ITRK, NMIC single copy, and aneuploidy is going to be there, develop less than, slowly it gets regress. But the stage 4 SN neuroblastoma, ITRK, NMIC single, aneuploidy, rapid growth, and regression. So this is one stage. Even in the stage 4 NBL is a unique one. And unfavorable cases is going to be low TRK, NMIC is amplified, classical diploid tumors, and they develop greater than 12 months and mostly death. And especially this one, ITRK and NMIC amplification very early. So before 6 months, you can see the tumor is so big, but it rapidly grows and also rapidly regress. That means this baby becomes even clear in 1.5 years. Totally the tumors are gone. Either they would have differentiated into a normal neuronal cells, or they would have undergone apoptosis. So this is the kind of phenotypes exist in the neuroblastoma. And the genetic abnormalities are very common. The triploidy is going to be leading to resulting in TRK overexpression, and that is why the triploidy is beneficial. And diploidy, in classical diploidy, most of the time we are seeing deletions or duplication of certain region. For example, MICN amplification is one, and then survive, and this is the unbalanced amplification is going to be 17q is also going to be exchanged with 1. So this is one thing. So this is the genetic regulation of aggressive. TRK is down, MICN amplification is there. So this is the kind of the genetic difference between the two different cancers. And then they were trying to map the region where the 1p deletion is there. In neuroblastoma, 36.123 and up to this level is completely deleted. And what is so my job was to identify the tumor suppressor present in this region. So by means of during that time, my lab was all the genome sequencing was not done, but my lab took the initiative of doing the sequencing and did the sequencing and find out the KIF1B gene is present in this region. And then if you ask what is KIF1B, is a classical kinesin molecule. It is a motor that is rafting on the microtubule carrying the cargo in their head, kind of a head, and it will be sliding on the thing. So you have a plus end motor, minus end motor. That means one is going towards the nucleus and another one is going from the nucleus toward the periphery. Being the neuronal cells, the cell body is going to be present in one place and the neurons or axons is going to be going to the end. So through the microtubules, what is synthesized in the nucleus, for example, mRNA is getting transferred to the synapse where the translation is happening. So that is the kind of job the kinesin is doing until then. And we were the first to show that kinesin could be acting like a tumor suppressor. So this is the background known. So they were deleted. They found out there is a synaptic vesicle and everything. And then my job was to find out that this is the classical KIF1B alpha and KIF1B beta. And then this is the classical structure, motor, FHA domain, PH domain. And then this is the death-inducing domain I identified, Kyle region responsible for creating a death. So if you overexpress KIF1B, all of them are dying. So the initial, when I went there in the lab, they did antisense mediated and then injected into tumor mouse cells and made the virus, and a small region, antisense region, is able to suppress the tumor formation. So this is the antisense region suppress the tumor, and they cloned it and they sequenced it. They found out it is the neuroblastoma, the KIF1B 500 base pair fragment. And then the frequent loss of LOH. So I screened the LOH for all the tumor samples, and I found out the LOH is very common. In the higher the stage, the LOH is going to be common. So that means the aggressive four stage, you have a 58% of LOH. So this indicates that this is important gene. So, and also by using a different marker, so we screened everything and then we identify the minimal region, and then we were screening for mutation, we are screening for the promoter changes. So I mapped the promoter region and then I checked whether the promoter is methylated by means of following the MS methylation specific PCR. And then I don't find any specific methylation, so mostly remains unmethylated. Whatever the favorable or unfavorable cancers, all of them remains unmethylated. So maybe KIF1B is not activated by promoter methylation, but one allele is deleted. So no mutation in the exon as well as in the upstream exon, only a few silent polymorphism. Copy number alanines indicated that majority of them LOH, and no mutation, but LOH indicate that this gene could be an haploinsufficient tumor suppressor. So I went on to identify that there are 4 different variants present in this region, resulting in this kind of deletion of this amino acid, getting this 4 different variant. And also I screened the gene expression in the tumors, favorable and unfavorable tumor. You can see that favorable tumors are overexpressing the KIF1B and unfavorable tumors are underexpressing the KIF1B. And this is showing the different variants, like 4 variants what I found it present in the brain and liver and cerebellum. They are expressing in a different level. And then I made the adenovirus construct and I express it. This is the KIF1B expression. And if you overexpress the KIF1B, the bottom, you just follow this. This is no KIF1B. This is KIF1B beta 1, 3, 4. And if you add this, they are inducing apoptosis, and you can see the subg1 population is increasing in the different populations. So it means this gene is inducing apoptosis, and also this is the colony formation assay. So the vector alone transfected cells were growing nicely, making colonies, and the gene transfected ones are going down, and the colony number is down, indicating that this could be a tumor suppressor. And in the same thing done in 2 different cell lines, that's all. And the actual mutations, what is present in this FHA domain conserved across. So this is the conserved domain. And then what I did is I mutated the FHA domain. I mutated the FHA domain and find out this FHA domain is not doing anything. So, and also these mutations were also identified as a mutation, but they are not causing any disease. So then I made a KIF1B knockout and by means of RNA expression. And then we found out the growth is accelerated in the KIF1B loss. If the KIF1B is knocked out, the growth is getting more. And this is going to be the clones expressing the RNAi. So you can see the downregulation of this KIF1B. And then we went on to fuse this KIF1B with the GFP and track them. And I'm able to show that they are inducing classical apoptosis, so the fragmentation of cells. And then the green fluorescence protein is the indicating the KIF1B. And then you can, if you follow this, the cells like this, 1 minute, 2 minutes, 5 minutes, 8 minutes, 39 minutes, 10 minutes, and I'm going to show you a video where you could. So what I did after that, I just made the truncation of this protein, this gene, and try to map this, whether the gene is, which area is critical. I found out this region is going to be the critical. So the plus means this is going to be the cell apoptosis. And up to this region, even without the kinase activity, still this is inducing. So this coil domain is responsible for the cell death function. And then this is the GFP alone. If you transfect it in 24 hours, all the cells round up and floats. So this is the image, the time-lapse image captured, and this image I have a movie I will show you, and you can see that step by step they become. They are floating. This is the one, actually dead one are floating like this. So they were starting like this, and finally they become dead and floats. And then the most of the time, what we found out, like overexpression resulting in a G2M arrest and leading to the death. That was through the cell cycle analysis we were able to show that. And then movie. So finally we were able to identify a tumor suppressor responsible in this 9p21 region, and this tumor suppressor is responsible for the spontaneous regression. And this is the paper, additional papers, while we were also doing. Another group and ourselves were joined, and they were working on phagocytochroma, and we jointly published a paper. They published in the Genes and Development, and we did in JBC. And I wanted to acknowledge the lab where I did my thing, Chiba Cancer Institute, and my professor Akira Nakagawa, he is the director of the institute. And this was really, we were the first to identify the tumor suppressor in this gene. And then I will show you one movie, because seeing is believing, right? So the green fluorescence protein is my gene expression. And then you can see that in a time lapse, this was every 5 to 10 minutes. I have captured the image and made the movie, and you can see that how the blubbing and everything, the cell is dead and started floating out. So other cells are normally dividing. If you look at the other cells, for example, so you follow this cell, this is going to be normally dividing, and this is going to die. And then this one is dividing, and you can see this one, it divided in front of your eyes, right? So the neighboring cells also, sometimes it received also going to dead. So this is the kind of work we have done. And thank you. So if you have any questions, I am available to answer anything. Hello?
Sir, thank you, sir.
Yeah.
Thank you for sharing your immense knowledge on molecular genetics in pediatric tumors and enlightening us about your insights on neuroblastoma, sir. Thank you, sir. And
That was a beautiful video presentation. We have not seen it before, sir. It was very nice to watch it.
No, that was made by me. I cultured the cells, and captured every 10 minutes overnight, and then combined everything and made it as a movie. I want to see really what is happening when I overexpress my gene of interest by tracking them with the GFP.
That was very nice, sir. And we had an opportunity to see it. Very nice, sir. Thank you so much, sir.
Thank you.
And it's open for the public audience to ask any question to sir. No
So
questions are
overview definitely is going to be a difficult task, but I'm not certain like whether I should bring more basic or more advanced. So I hope like I've given at least something to highlight the genetics.
It was very informative for us, sir.
Okay, thank you.
Sir, actually, it's a wonderful presentation, sir. You're covering all aspects of cancer cytogenetics. Our aim of this seminar is to actually it's a real eye opener for the cancer cytogenetics. So
Right.
generally, people are thinking cytogenetics means they are more about this constitutional cytogenetics only now and molecular cytogenetics. And they know very few things only in the cancer cytogenetics. You have covered extensively, and it's a wonderful, really is an amazing presentation, sir. Thank you so much. Because here, not only the audience, only from the even CRRA they are registering. So basics to CRRAs to students, MBBS students, MD pediatricians and pathologists and cytogenetics, and some people from Anna University biotech students also there. So you have covered each and everything entirely. It's a wonderful presentation. Thank you so much, sir. Thank you so much.
Thank you. May I sign off now? Yeah, somebody is asking.
There is a question posted, sir.
Okay.
In MPL exon 10 mutation with out of range W515L mutation lesion, what does it indicate?
So MBL, I'm not that much expert. I'm working on solid tumors of adults, and I was there working on pediatric tumors. And since you asked me to cover on pediatric tumors, MBL, if I can read it, I can highlight it. So where is exactly that person can talk? Can the individual can ask specifically?
Divya Priya has asked a question.
Okay.
I request Divya Priya to come unmute yourself and ask the question in person.
Good morning, sir.
Yes, madam.
Sir, this is a case which we got, sir, on a genetic test which was done for MPL mutation in ET patients, sir, essential thrombocythemia.
Okay.
So they gave a result of out of range.
So they have given this mutation as one.
Yes, sir. Yes, sir.
Could be probably. So this is only an isolated case, or you have a trios? So you have the family. Is it a somatic or genetic?
Somatic, sir.
Somatic mutation.
Yes, sir. Somatic mutation. Case of IG nephropathy case with this MPL mutation.
No, if you can share me, take my email ID and share me the detail. I can help you and I can read and get you more detail if you want.
Sure, sir. Sure, sir. Thank you. Thank you, sir. Thank you.
Yeah, sure.
So they can share your mail ID so that we can post it to the other.
AK Munirajan.
Yes,
AKMUNIRAJAN Munirajan @gmail.com.
All small letters, sir.
Anything is okay.
Can you akmunirajan@gmail.com?
Yeah, correct.
Yes, sir.
Yeah, please share. I will find out even additional details about this one. Okay.
Thank you very much, sir.
Yeah, thank you.
With this, we'll move on to the next session by Dr. Kalpana, madam.
I'm happy to introduce our next speaker,
Yeah.
Dr. Kalpana Gauri Shankar ma'am, pediatrician and genetic specialist at Apollo Hospital, Greens Road. She has completed her PhD in medical genetics at Dr. MGR Medical University. Madam has a wide experience in the field of clinical genetics. I request you, ma'am, to share your clinical knowledge with us.
Can you see it? Can you see my slides?
Yes, ma'am, it's visible, ma'am.
Okay.
Can you make this a full screen?
It's okay. Just bear with me for a minute.
Yes, ma'am. Your screen is shared and it is visible, ma'am. You can make it as full screen, ma'am.
Yeah, but I'm not able to do slide, not doing.
When you go to the slideshow and click on from the beginning, ma'am. The slideshow, that's home, insert, design, transition, animation, and slideshow. Just click on the slideshow.
Now, is it visible?
It is not yet, ma'am.
It's not visible?
The screen is visible, but it is not coming as a full screen.
Okay, it is coming in mine, actually. Now?
Yes, ma'am.
Now is it okay?
Yes,
Okay. Good afternoon to all of you. At the outset, I'd like to thank Dr. Papati and her team for inviting me for this webinar. I was in ICH 40 years ago as a DCH PG, and 15 years later, I came back to do my PhD in IOG. So this is kind of my special thank you to my alma mater. In the next few minutes, I thought I could tell you in a nutshell what genetic counseling is all about, when we do it, what is the procedure and how we do it. And then I would share a few cases that I have seen during my time as a clinical geneticist, and how it was earlier before the genomic era and now after the genomic era. So what is genetic counseling? Genetic counseling is a process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. The components of genetic counseling will be: first, interpretation of family and medical histories to assess the chance of disease occurrence or recurrence. The next important aspect of genetic counseling is educating the family or the patient about the mode of inheritance, testing options, management protocol, how to prevent complications related to the syndrome or the condition, what are the resources available and the research that is happening regarding treatment or diagnosis, etc. And the next important component would be counseling, education and counseling. Counseling is to make the family understand the disease, help them make informed choices, and help them adapt to the risk or the genetic condition. Who provides genetic counseling? It is both genetic professionals who can be medical and non-medical professionals, and more importantly, it is particularly in a country like ours, it is primary healthcare provider, because we have a dearth of genetic professionals in our country. Maybe it will improve with time. Where does a genetic counselor work? It can be clinical or non-clinical. It can be in the specialty clinic. It can be in the prenatal or a pediatric clinic or a cancer clinic. Or in the non-clinical side, it can be in research lab doing clinical trials, in a diagnostic lab making telegenetic counseling, report writing, or in a pharma company or in public health organizations. So what happens in a genetic counseling session? First important point would be to gather information. A detailed 3-generation pedigree will help you get all the details about the family history and the medical history of both sides of the family. Then you evaluate, interpret the results, physical examination, head-to-toe examination of the patient, and most importantly, make the diagnosis, because your counseling is going to hinge on your diagnosis. This is only if you get a diagnosis, you can plan recurrence risk estimation, you can do prenatal testing, or you can plan preventive management techniques. Then comes communication. A counselor sits in a proper place where there is adequate quiet, where the person can concentrate to what you're talking. And it's a two-way process. It's not just you talking, telling all about the disease, but you will also have to be tuned on to the asked and unasked questions of the family. Some of them may not be able to vocalize what they're feeling. So you must be tuned to what they're thinking and help them out. The next important part would be to support help the family cope, and to also have a follow-up, maintaining an ongoing communication, have a follow-up with your family. So the cornerstone in genetic assessment is a 3-generation pedigree, and all of you know how the symbols, different symbols, and how when you make a shading, it means that the person is affected. And this is clearly both sexes are affected, and it's a vertical pedigree, and this is an autosomal dominant pedigree. When is genetic counseling provided? It can be at the preconception clinic, it can be prenatal, it can be pediatric, or when the person, it may be an adult who comes to you for counseling. In the preconception counseling helps you identify women or couple at risk, because there may be a family history of birth defects or genetic diseases. You can ask about the medications that the lady is taking. It may be anticonvulsants, it can be anticoagulants, it may be anti-thyroid drugs or anti-cancer drugs. And this will be a good time to talk to them about harmful effects of smoking, alcohol congestion, and also any illicit drugs, or cocaine, LSD, etc. This is a time to talk about age-related risk. We know that maternal age higher than 35 years carries with it a risk of chromosomal aneuploidies in the offspring. Likewise, a paternal age above 50 years, you can get new autosomal dominant mutations. And also, if there is a particular ethnic group, you can talk about carrier screening. And this is a very good time to talk about the periconceptual folic acid, how it can bring down the levels of neural tube defects coming in the offspring. I'll just take you through some of the cases as we go through our talk. This gentleman was a 29-year-old person. This is the consultant. I have put an arrow. This is the consultant. He was and he was 33, and he had a sister with beta thal intermedia, and he was a carrier himself, beta thal carrier. He carried the trait. His parents likewise had the beta thal trait, and he had a whole lot of cousins who had this thal trait. Now, his prospective bride happened to have hemoglobin E trait. Now, he was worried about his offspring risk. He has obviously read in the internet about this, and he came to the genetic clinic wondering whether he should go through this proposal or not. So, as I said, he's a known beta thal carrier, and the prospective bride is a hemoglobin E carrier. We all know that hemoglobin E is a very mild beta variant, and the carrier also doesn't normally exhibit any phenotype. However, there is, when they mate, the risk, if we put the panel chart, you find that they have 25% risk for hemoglobin E beta thal. Now, this has a very, this is a spectrum, and it can be very mild, or it can be transfusion dependent, and supposedly this is the most common type seen in Southeast Asia, sometimes as severe as homozygous beta thalassemia. 25% of his offspring can have beta thal trait like him. 25% there is a risk of hemoglobin E trait like the mother, and 25% chance of being normal. So when we did the risk estimate and discussed with him, he seemed clearer, and he was able to take his next step forward. Coming to prenatal genetic counseling, most often it is a advanced maternal age. The mom comes because she's worried about her Down syndrome risk, or it may be because she has an abnormal, she comes to you with an abnormal prenatal screen, first trimester screen positivity, or there is a family history of suspected or known birth defect or chromosomal abnormality, or she's terrified that she didn't know she was pregnant and she had taken a drug and she didn't know whether it would harm the fetus, or it is a mother with a medical condition like diabetes mellitus or myotonic dystrophy or SLE. Sometimes it is a mother who comes with 2 or more pregnancy losses, or it may be consanguinity. They are concerned that they are consanguineous. Now, a lot more young people are concerned about consanguinity, and or it may be because of an ethnic background related to a higher risk. This was a mother who's 29 years old. She's been married for 5 years, and she's lost a 13-year-old brother whom she thinks had Duchenne muscular dystrophy. She remembers she had high CPK and no DNA analysis was done at the time. She already has one normal female child and is currently 8 weeks pregnant, but she's terrified. What if I have a male child, and what if he has DFD? This is the pedigree. This is the consultant. She came to me. She's currently pregnant, and she has lost a brother with possible Duchenne muscular dystrophy. She doesn't know whether she's a carrier or not. So we know that Duchenne muscular dystrophy is the most common neuromuscular disorder affecting males. It's an X-linked recessive disease with the gene in the short arm of chromosome X. It presents with proximal muscle weakness, cardiomyopathy. It's progressive, wheelchair bound in teens, and death by 20 years. And 70% of the cases are caused by a deletion in the DMD gene, and 30% may be because of a duplication or a point mutation. So now we do not know, because her DNA testing was not done for her brother. She may or may not be a carrier for DMD, but if she is found to be a carrier, being an X-linked recessive disease, you all know, there is a 50% chance of having an affected son. And if it's a daughter, there is 50% chance of having a carrier daughter. What next? Now she's confused whether to have carrier testing or not, because in our country, we are not allowed to have the sex of the fetus revealed. The lab will only tell you if the mutation is positive, there is a mutation or no mutation. So even if it is a girl who's only a carrier and not affected, termination of pregnancy is the only option currently in India. Mrs. N is devastated, overwhelmed by this, but thinks about it and decides to go ahead and do carrier testing for herself. What does a genetic counselor next do? Orders genetic testing for carrier status DMD by doing an MLPA analysis. The results come after 4 weeks and are found to be negative, and Mrs. N is relieved and continues her pregnancy and goes and has a normal son. What about pediatric genetic counseling? It may be, as I said again, it may be abnormal. You may be, the genetic counselor is asked to because the newborn screening has come positive, or it may be a child with one or more birth defects. It may be a child with tall stature or short stature, child with developmental delay or congenital blindness and deafness, or as I said earlier, there may be a family history. This is the counselor is called to the nursery because the baby has dysmorphic features and has a congenital heart defect. It is atrioventricular septal defect. All of us know this is Down syndrome. The phenotype is striking. This is a Down syndrome baby. What is Down syndrome? We have already heard a lot about Down syndrome, and today is the Down syndrome day. We know that it's the most common chromosomal cause of mental retardation, occurs in about 1 in 700 births. Full trisomy is seen in 95%, translocation downs seen in 4 to 5%, and mosaic downs is seen in 1% of cases. The clinical concerns are congenital heart defect in about 50% of cases, hearing and ophthalmic issues about 30 to 80, and hypothyroidism in another 30 to 50. And they can have behavior defects like ADHD, autism spectrum disorder, etc. So what does a genetic counselor do? Arranges for chromosomal analysis for the baby, and bingo, it is trisomy 21. And the next would be talk to the family about the preventive management planning, order an echocardiogram, do thyroid function testing, ophthalmic and hearing assessment, arranges for early intervention therapy. And the family now wants to know the recurrence risk. What about the next baby? Because this is a full trisomy, we know that the recurrence risk is as low as 1% more than the average population age-related risk. It is just 1% more. And if the family is still not ready to take even that 1% more risk, we could help them out with doing a first trimester screen or a non-invasive prenatal testing using cell-free DNA. Coming to adult genetic counseling, it may be for intellectual disability, family history of hereditary cancers, or there is a history of genetic conditions in the family, or development of degenerative disease. It may be the infertility clinic, the man or the woman facing infertility for pregnancy planning, or it may be because reproductive clinic for recurrent pregnancy loss. Genetics may be straightforward, but addressing family concerns may not always be straightforward. Now, this lady, Mrs. B, was 30 years old, and she has had isolated bilateral cleft lip and cleft palate, for which she has had several surgeries in the past, ever since her birth. And now she's married for 3 years. It's a non-consanguineous marriage. And there is the family history is, there is no pertinent family history except for the cleft lip and palate in her. And she's currently 13 weeks and 5 days pregnant. She comes to the genetic clinic, prenatal clinic. She's currently the 12th, because 12th week ultrasound has picked up a unilateral cleft lip and cleft palate on the left side in the fetus. She is absolutely devastated because as a child, she has gone through innumerable surgeries and therapies. And so she was hoping that her baby would not be affected. This is the pedigree. Both sides of the family is clear. And she is the proband who's had bilateral cleft lip and palate. And this is her pregnancy with unilateral left-sided cleft lip and palate in the fetus. So how do we counsel her? We know whenever you have cleft lip and palate, you have to make sure it is isolated, or if it has other anomalies, because we know a whole lot of syndromes can have cleft lip and palate, right from your 22q deletion, your Stickler syndrome, your EEC syndrome, van der Waals syndrome. There are so many syndromes with cleft lip and palate. So then the recurrence risk becomes different and the counseling becomes different if it's a syndromic cleft lip and palate. If it is an isolated, most often it is multifactorial, the recurrence risk is very low. But in this family, because a mom has bilateral cleft lip and palate, we'll have to think of autosomal dominant inheritance also. So during the counseling, I was able to tell her to go ahead with a 20-week scan where the fetus can be examined head to foot and see if we can pick up other anomalies and to see if it still continues to remain isolated or a syndromic. If syndromic, or if she is very worried about the inheritance, we could do amniocentesis at 16 weeks and do DNA testing, exome sequencing. For example, MSX1 gene causes autosomal dominant cleft lip and palate. We can look at any of these genes. So this was the counseling given to the mother. Coming to the current era, genetic counseling in genomics era. What is a genome? Genome is an organism's complete set of DNA, including all its genes. Genomics is a study of all of a person's genes, genome, including interactions of those genes with each other and with a person's environment. And genomic technology, we mean next generation sequencing, which could be whole exome, whole genome, or gene panels. Understanding genome sequencing and variant interpretation is an important part of the knowledge of the genetic counselor, and in the next few cases, you will understand why. So we have moved a lot from the 70s. In prenatal genetics in the 70s, all we could offer was carrier testing. Then prenatal diagnosis became possible. Now is the era of pre-implantation genetic testing. Pediatric genetics from single gene disorders, we have moved on to diagnosing rare diseases. And cancer genetics, in the previous lecture, Professor Muniratnam told us how even genetics has come as far as not only risk assessment, but also in treatment guidance and screening for lapses, etc. And so on, pharmacogenomics and ancestry tracing, etc. We have come a long way in genetic testing. And yes, earlier we were doing karyotyping, FISH, MLPA, etc. Now we have the genome, NGS has come, we can do the gene panel, we can do whole exome, whole genome, and other things. I thought I could share a few points about chromosomal microarray, because this has also helped us pick up more genetic disorders. Like karyotyping, it is whole genome coverage. Like NGS, it is whole genome coverage. But unlike karyotyping, it can pick up, as a resolution is very high, it can pick up a variant as small as 10 kilobases. And because of the high resolution and whole genome coverage, this has become the first tier test in the West. So this is the workflow, and where the patient and control DNA are labeled with, it is something like your FISH, except imagine a FISH using 1,000 probes in the gene chip. It is something like that. The patient and control DNA are labeled with fluorescent dyes and applied to the microarray. Array is a small chip having multiple probes, and they are made to compete to attach to or hybridize to the microarray. The microarray scanner measures the fluorescent signals from them, and you have a software which analyzes the data and generates a plot. It will tell you whether there is a duplication or a deletion. which cannot be picked up by the conventional karyotype. So indications for microarray are any child with developmental delay, multiple congenital anomalies, dysmorphic features, the test for autism spectrum disorder. Whenever you have abnormal phenotype, you think it is chromosomal, but your karyotype comes back as normal. POC testing, products of conception testing, and marker chromosomes. Microarray helps you in all these conditions. The results will come as copy number variants. And how do we tabulate it? It can be a benign variant which is present in normal population and has been already reported in literature and curated database. There's no abnormal phenotype related to this variant. Or it can be a pathogenic variant which is already associated with known microdeletion, microduplication syndromes, and has been already reported in Decipher, PubMed, OMIM, etc. Or it can be a variant of unknown significance, neither here nor there. So this was a child who had developmental delay dysmorphic features with a normal karyotype. And when we did the microarray was ordered next, we found that this baby had a duplication with 17.8 megabase in the long arm of chromosome 4 and a deletion, heterozygous deletion, which is 15.3 megabase size. This was both pathogenic variants in the long arm of 18 chromosome. So this explained the child's dysmorphic features, developmental delay, even though the karyotype turned out to be normal. This could not have been picked up by our conventional karyotype. So to sum up, it is a first-tier test for mental retardation, multiple anomalies, autistic spectrum disorders. It has a whole genome coverage. It has a higher resolution, no cell culture needed, and it is useful for microdeletions, microduplications, cryptic imbalances, and also to identify marker chromosomes. But you have the downside of the high cost. There are various platforms. You're confused what to choose. That may be incomplete penetrance with the copy number variant which has been picked up. There may be, as I told you, it may be a variant for which we don't have data, whether it's pathogenic or benign. And it cannot pick up low-level mosaicism, cannot pick up balanced chromosomal rearrangements, balanced inversions, insertions, point mutations, or methylation disorders. So for this, chromosomal rearrangements and inversions and balanced insertions, we still have to go back to our gold standard karyotype, conventional karyotype. Remember, it is also not indicated for single gene disorders. So we move on to next generation sequencing, and this is the most, I would say, the most powerful diagnostics tool after X-rays, because it facilitates diagnosis on a massive scale, allowing interrogation of all genes in a single assay. So we have different applications. It can be a disease-targeted gene panel. For example, you have a cardiomyopathy. So lots of genes can cause cardiomyopathy. So you will have a panel, cardiomyopathy panel, or deafness. You know, over 200 genes can cause deafness. So you have a deafness panel, retinitis pigmentosa panel. So you can have targeted panel, okay? Or you can have clinical exome. And clinical exome is like it limited genes. It looks at about some labs 6,000 genes it covers. For some labs it is 6,000. For some as much as 8,000 genes are covered. They are only known disease-related genes, and whole exome covers all the 22,000 genes, but only the exons of all the 22,000 genes, and whole genome covers not only the exons, but the introns and the splice sites. It covers the entire genome in the test. The TAT is turnaround time is 4 weeks, and the cost for a panel may be 15,000, or it may be $150,000 for a whole genome. So this slide tells you all the different advantages and disadvantages. As I told you, gene level is variable in a panel. It may be a small panel having only 10 genes, or it may be a panel having 200 genes. It all depends on the disease. And when you order panels, remember to see if you have a gene in mind, and see, you ask the lab for the panel, what the panel is offering, and you check out if the disease, if the gene that you have in mind is covered in the panel. And the advantage of a panel would be the high coverage and less of VUS, and it covers pre-selected genes and can pick up deletions, indels, etc. But the limitations are only pre-selected genes, and it suppose new genes, and every lab may not frequently update the panel, so you'll have to be constantly seeing if the gene that you have in mind is present in the panel or not. That is the limitations, because it is pre-selected genes. Just like how fish, it's a single probe, means it's a single defect that you're seeing. Just like that, the panel is also limited. Coming to clinical exome, the candidate genes are covered in OMIM, ClinVar, HGMD, and ACMG. And compared to the whole exome and whole genome, the cost is less, because the number of genes are covered are less. It is accurate, high coverage is there. You still get variant of unknown significance, but they are less compared to whole exome and whole genome. But remember, it cannot pick up translocations, it cannot triplet repeat disorders, it cannot pick up gross structural rearrangements, and methylation imprinting disorders, it cannot pick up. Coming to whole exome sequencing, it covers about 20 to 23,000 genes, only the exons. That means only 2% of the genome, it covers only 2% of the genome, but it covers 85% of the disease genetic disorders. And it covers the variants in coding. The advantages are it covers the coding regions, splice sites, and it has an increased coverage compared to your clinical exome and your gene panel, but it will not tell you about non-coding regions. And again, the high cost and a huge data interpretation is a big issue. Now, the whole genome is the final one. It covers entire genome. Both exons and introns and UTRs and intergenic regions are covered, and the coverage is more uniform, unlike your whole exome, where some exons may be missed. Here, because it is not picking up only exon, it's covering the entire gene, the coverage is more uniform, and the cost again is prohibitive. So ACMG guidelines, according to ACMG guidelines, if based on the databases and the in silico predictions, they are divided into benign, mostly polymorphisms or likely benign. Then you have variants of unknown significance, like in your microarray, where it is still not known whether it's pathogenic or benign. Then you have pathogenic and likely pathogenic. Both of these, your treatment for the either testing for the family members or your treatment, this is more, you can treat both as one. Probably the evidence is more complete in pathogenic, and likely pathogenic, you need little more evidence to clinch the diagnosis. So what are the challenges in this era of genomic counseling? Sometimes you get dual diagnosis. Now, I remember the neurofibromatosis is so common in our population. I've had some children with Rett syndrome and neurofibromatosis. You have glycogen storage disease with neurofibromatosis. And recently we had a child with Miller-Dieker syndrome along with neurofibromatosis. Because of two genetic disorders, the phenotype may be blended and it can be confusing when you are doing the phenotype. Then you have something called incidental or secondary findings. It is this, I will explain to you with your cases. And then you have already, I told you about variants of unknown significance. And then you have, sometimes you have unexpected diagnosis. It may not be the diagnosis that you thought of, and it can be a totally new one jumping on you. So you'll have to, you will be in a quandary as to how to go forward. Coming to the case number 5, this was a 9-month-old male baby. He was born to 3rd-degree consanguineous parents. He was the first child. He came presented with failure to thrive. He had global developmental delay, dysmorphic features. He had facial asymmetry, preauricular tags, and most importantly, he had multiple fractures, about 4-5 fractures in the course of 9 months, and he was also operated for congenital cataracts. The karyotype was normal, and in a previous lab, because of the fractures, osteogenesis imperfecta panel was ordered, and it was negative. So this is the baby. You can make out the bent limbs because of the fractures, and you can see the protuberant tongue, and the asymmetry is not very visible in this view. And this was a baby. His parents were consanguineous, 3rd-degree consanguineous, and the family history was positive. One child had learning disability, hyperactivity, another had a holoprosencephaly sequence, and it was a very complicated pedigree, as you can see in this. And when we did a whole exome sequencing, he had a pathogenic biallelic variant in TAPT1 gene, and this was a frameshift mutation. And this is along with that, he had a pathogenic variant in G6PD, which was maternal in origin. We had done for the parents also. The TAPT1 gene mutation he had got from both his parents, and this was from his mom, and that explains the X-linked recessive inheritance. And he also had a likely pathogenic variant in LDLR gene, which was biallelic. So how do we explain to this family? They are not very literate people. Already they are confused about the so many affected family members, and this baby with such a bad phenotype. And we had prepared them pre-test counseling. We had told them that we were looking for this phenotype of developmental delay, dysmorphic features, failure to thrive, fractures, and cataracts. Now, this, when we looked up the literature, TAPT1 related lethal osteochondrodysplasia, his phenotype definitely matched with this pathogenic mutation which was found in him. But what about G6PD, the pathogenic variants in G6PD? What about LDLR, likely pathogenic variant? We had not prepared the parents for this, and the counseling, post-test counseling took quite a while, explaining to them that he may have to avoid certain drugs, and this was certain drugs, and likewise for LDLR, that we may have to think of doing a lipid profile in future. And so explaining this phenotype and the recurrence risk was complicated because of their background, and having 2 more additional findings to explain to them was quite a challenge. But of course, with patience, we were able to convince them and talk to them about these reports. Moving on to the last case, this was a newborn. This was non-consanguineous parents, young parents. This was a second baby. The first child was normal. There's no pertinent family history. This baby was 1.5, I think, 1.5 kilo, presented with IUGR, predominantly ocular anomalies. He had severe blepharophimosis, optic disc hypoplasia, and retinal dysplasia. So a clinical exome sequencing was ordered. We found a frameship likely pathogenic variant in COL6A3 gene, which is related to muscular, autosomal dominant muscular dystrophy. Now, this was very confusing. The newborn did not have any features of any muscle disorder. All the baby had was IUGR and very predominant ocular anomalies. And there was no match, apparent match between the variant found and the phenotype. At 9 months, when the baby was brought for a review, we found she still continued to have postnatal growth retardation, and in addition, she also had spastic, all limbs were spastic, had pulmonary hypertension, bilateral small kidneys, MRI features were also abnormal. She had cerebellar vermis and the tonsils were all hypoplastic, and also the also I think dysplastic corpus callosum, and she was definitely delayed. Development milestones were grossly delayed. So this time we ordered a whole genome sequencing. Whole genome sequencing was done, and in this we were able to pick up because this can pick up even microdeletions and duplications. There was a large C7.2 megabase deletion was seen in the short arm of chromosome 3. Okay, this was later confirmed by a microarray also. This deletion was confirmed by doing a 750K microarray, and these are the genes which are found missing in this microdeletion. And this explained all the phenotype: failure to thrive, global development delay. She also was found to have choanal atresia, spastic limbs, pulmonary hypertension, small kidneys, and central nervous system brain anomalies. The earlier frameship mutation likely pathogenic variant was also there, this time also the COL6A3 mutation. And in addition, we had a frameship mutation uncertain significance, which was class 3, and this was in the PUM1 gene. This causes spinocerebellar ataxia, where so we had to explain all this to the family. We are not very sure, maybe a year from now, we could ask the lab to reclassify whether this frameshift uncertain significance variant has been reclassified as benign or pathogenic. So this was the plan that we shared with the family, and they were parental testing was offered to see if it was de novo aberration, chromosomal aberration, or whether it was inherited from one of the parents, and they did not come back for the further testing. So lessons learned from this child was a clinical follow-up is essential if there is no genotype or phenotype match, and if there is still, when you do a deep phenotyping and you don't come up with any, it still doesn't match, then you'll have to think of additional testing or ask the lab whether they could do reanalysis. And most importantly, you have to do pre and post-test counseling, because if you don't, the reports, it's like opening a Pandora's box. When you get the report, you have it may not be one gene, as I showed you in the previous case. It may not be one, it may be 2 or 3 genes, and you have to prepare the family and ask them whether they would like to know only testing in the West. This in the pre-test counseling, this itself is clear. Ask them whether they would like to find incidental or secondary findings, whether they would like to know about it, and the parents say yes, then the counselor talks about the other findings, with secondary findings related to the proband. So remember, the principles of genetic counseling is still the same: autonomy, beneficence, non-maleficence, first do no harm. And remember, it's non-directive counseling. You explain all the pros and cons of the condition. You give them all the help give them all the facts and let the family decide whether to go ahead with testing or not testing. Privacy, respect the privacy of the patient. And if you think you're doing a pedigree and if you come across non-paternity or any irrelevant data which may not be useful to this condition, please do not do it in a open chart, because the chart can be read by other people. So be very careful, think about what to talk and where to talk, and allow the family to choose. So impacting factors in genetic counseling would be most importantly language. India is a country of many languages, and counselors should be multilingual. And so because explaining all this variant of unknown significance, genes, exons, introns, if you don't know the language, it becomes very, very, very difficult. And religion, people of different religions view life and death differently, and this becomes important when reproductive options, particularly terminations or assisted reproduction technique, and the method of grief for loss is very, very different in different religions. And in our country, family dynamics play a big role, and when you ask for the parents to come for counseling, invariably a whole family descends comes to your room, and it will be the grandmother who's doing the talking, and the mother-in-law doing the talking, and the daughter-in-law stands silently, not able to ask any questions. So you will have to have an idea about the family diagnosis and their view on disability, what they think about disability, and what they think about Western versus traditional medicine and compliance to medical follow-up. All this is impacted by cultural differences. So genetic counseling uses the ever-increasing information and technology of contemporary science and applies it to human experiences that are age-old in their impact on individuals and society. The science is contemporary, but the hopes, fears, and anxieties surrounding genetic disorders and birth defects remain unchanged as of before. I'd like to stop with this. This is my team from the Department of Medical Genetics, Dr. Indumati, and my whole bunch of helpers who help me often with my genetic counseling sessions. A big thank you to all of them.
Thank you, ma'am. The cases were really very interesting. You have given us a wide knowledge and importance of genetic counseling, and also have created an awareness of genetic counseling. Thank you, ma'am. Thank you so much.
Thanks a lot.
I would request the audience to ask any questions to ma'am.